read everyone's name, but all of you are welcome and thank you. Okay, the webinar is live stream now on YouTube as well. So there will be many people who will be watching that, and people are slowly increasing. Okay, so good evening, good morning, good afternoon, everyone. Welcome. Welcome to the Global Advanced Certificate Program, and under the aegis of that, we are running this advanced training series on research methods in health and ethics. So today's guest trainer is Dr. Rounik, okay, and so he's here already, okay. But before I go to give him the thing that he has to offer, he has a lot of very interesting things to offer to all of you. So I'll take it a bit slow. I'll first have to do a bit of the usual procedure that I have to introduce himself. So he had sent me his bio. I'm trying to find it out here because I have just come from one of the meetings, and so apologies that I'll have to find it first where it is. Okay. Usually I'm more organized than this, but today I'm a little running like this. Why? Because actually I have just completed the interviews with some new tutors who are joining us, international tutors.
Okay.
And yeah, they're very interesting profiles actually. Very interesting.
Recording in progress.
Ronnie, did you send me the bio as a document or like how did you send me?
I'll just highlight that. Yeah.
Okay, you highlighted that in the thing, right?
Yeah. Okay, I have highlighted in WhatsApp.
Wait. Yeah. Just because I'm trying to do that here, taking a bit of time. Yeah. Sorry, I'm not able to find it. Can you please send it back again? That
yeah, sure.
Because on the Mac it's looking very different. On the phone it looks very different. I think I've saved it. I don't know where it is. Yeah, you have sent me this document and I had downloaded and kept it, but I don't remember where I kept it. Okay. You'll not believe the amount of stress that I'm going through for the past 1.5 months. It's very embarrassing to say that on a live call, but that's the reality. Very embarrassing. Okay. Yeah, okay. So what I'm doing is I'm saving it now and I'm going there and I'm going to print it out from there. Just give me a second. It is saying it is saved, but it's not saved, which is very strange.
Should I send you the text? There's the text.
No. It's there. Yeah, now it's there. Yeah. Sometime when we are on meeting, no, it becomes low a little bit. That is the reason why it was not shown. Okay, so now we are good to go. Sorry, apologies for 3 minutes late. I think we are good to go. That happens. We are operating as per Indian punctual time, so it's fine. But we always try, because this is a global program, so we are always on time and we start in advance. So welcome Dr. Rounik Talukdar on the stage of Global Advanced Certification Program on strategic research collaboration and communication for young emerging researchers from all over the world. Okay, we have 800 plus participants from the Global Advanced Certification Program itself. And then in addition, we have participants for the workshop series, okay, which is so far the registration, if we count it, it is more than 800 again. So it is about more than 1600 plus participants that have registered so far, and many participants attend it live, and many of them actually attend it on YouTube and asynchronously later. Okay, and we give them everyone an equal opportunity. We are trying to engage and create a platform so that participants from all over the world, especially from lower middle income countries, get an opportunity to be handheld, to be provided the right kind of mentorship and guidance all at the same right time, so that they can emerge as the future leaders in the global south. Okay, we always talk about decolonization, we talk about decolonization in global health, we talk about health system strengthening. What we are doing, in fact, what I was talking to some of the very eminent people who are going to join us very soon as tutors and co-tutors, we are actually doing decolonization in real life, in real. So we are translating decolonization into practice. So welcome to our stage. So let me read out a small little bio. I think it's a very humble bio for the kind of stature that our young researcher here holds. So I'm very, very fond of the person that is sitting in front of me virtually, and I would like to meet you very soon in the future. So let me read it out and let our participants know about the talent base that we have in store. Dr. Rounik Talukdar is a public health learner and epidemiologist, currently working as a PhD fellow at the National Cancer Institute, AIIMS, New Delhi. He holds an MPH from JIPMER, that is Jawaharlal Nehru University, right? Jawaharlal Nehru Institute.
Yeah. Postgraduate medical research.
Yeah, postgraduate medical education research, Pondicherry, and a BDS from Burdwan Dental College, that is in West Bengal. His research focuses on infectious diseases, evidence synthesis, especially through systematic review, meta-analysis, and health policy, with over 15 peer-reviewed publications in reputable journals. And that is probably one of the reasons why he is very well sought after, because he is fast emerging as an expert in this area. Previously, he worked with the Indian Council of Medical Research, ICMR, on projects related to cholera and COVID-19 vaccines, and served as an epidemiologist as well. He is skilled in statistical analysis and has attained training in policy development from the University of Washington, Seattle. He has recently started an organization named Nibandha. I have gone through that organization's website and that social media page. I think it's very, very interesting and appealing. Okay, Nibandha is a center of evidence synthesis, is a LFP, and NCES empowers researchers, academics, and practitioners with advanced skills in evidence synthesis, specializing in systematic reviews and meta-analysis. So you seem to be doing some of what we are doing, and there comes the convergence. Yes. So there is a little point of convergence, and I think no small drop is small enough to fill the ocean. I think every small drop is very, very essential to fill the ocean, and what you are doing is phenomenal. It's very, very interesting and very vital to health system strengthening in lower middle income countries. And I think you have a very focused goal and mission and objective with which you are working, your center is working. And I wish you all the good luck with that. We look forward to have you on board as a member of the global consortium. Hopefully you will join us. We have more than 250 members from all over the world who have joined us as organizations. Okay, so we are fast growing, and right now the global consortium of global health actors, leaders, and thinkers is the largest global consortium on global health that is based in lower middle income countries in the global south. Okay, we have more than 2,000 members who have dedicated applications made via a application portal using their CVs and all credentials. Okay, no other website, no other organization can claim that they have all the verified documentations of all 2,000, 5,000, whatever members they're claiming, they have that, but we have that. Okay, so we can claim that yes, we have 2,000 dedicated members. Okay, so therefore you're welcome once again, Dr. Rounik Talukdar, on our global stage. And yes, we are very happy to have you. Now the session will start. The format is, it's a very interactive session. You are free to conduct your session as you wish. Okay, you have the access to share your screen, and feel free to engage them in any form of game, activities, whatever demonstration simulations, and I think our young learners as well as the older learners, whoever is watching us, they are very, very interested and keen to learn from you and from all the wisdom that you have. And the floor is all yours. Thank you.
Thank you. Thanks a lot. Thanks a lot, sir. Okay, so we would start today. Now, in a 2 years, in a 2 hours of time limit, I don't know if I would do a justice to you all. And mostly, I have seen the experts who are giving sessions. So, people who are senior experts, they tend to minimize their PPTs, their talks in such a way that it becomes so much valuable. And with very small talk, they can convey a lot. But us, like novice researchers or who are just starting out, so we generally tend to flood out the informations. Today is also no different. I have done the same. I hope that I'll do again some justice. I'll share my screen. Screen sharing is allowed, right, sir? Okay, so I hope the screen is visible, the first slide with the evidence pyramid. Okay, so everybody, I guess, know this, the evidence pyramid. Well, we say that systematic review, meta-analysis, a well-done one is that at the top of the evidence pyramid. I won't waste much of my time behind this. Um, let's so first a little history, because who doesn't love history? And history is very important also. And I don't know how many of you have how many of you have known this individual. He is Dr. Hans Seisnick. So he's a British psychologist, and he, in his 1940s, you can say the inception of meta-analysis come from his work, not directly, like he did not do a meta-analysis, but the inception of idea, among others, came from his activities, his one seminal paper. So he was a psychologist, as I was saying, and the main thing he was very famous of is because of the personality traits that he has given. You all know the big five personality traits like extrovertism and conscientism, and then someone may be introvert, someone may be psychotic. So there are five big traits. Now, among them, this psychologist gave two traits. One is extrovertism and another is psychotism. Now, anyway, he was a big advocate for behavioral therapy. So, how behavioral therapy can bring change in human life. But he was a lot of against psychotherapy, that is, psychoanalytical models, how just talking to an expert can change, can elevate your life, can elevate your mood. He was a big against it, and he had a paper in around maybe 1940s. He had a seminal paper where he bashed psychotherapy like anything. He directly told that psychotherapy actually does not work, and he is actually a very what can I say, a colorful personality. Like, first of all, this psychotherapy thing, then he went on and claimed that cigarette cannot does not causes cancer. Rather, he said that there is a link between personality, cigarette smoking, and cancer. And this particular research was funded by a tobacco company. So when he was asked, how is this? How is it possible? He just went ahead and told, no, tobacco company can fund this. The research has to be correctly done. That's all that is matters. But anyway, again in his career, the another conflict, a dramatic moment was one of his PhD students went ahead and told in his one of the papers that racial differences in intelligence were inherited, and he proudly defended that. So this is some of the trivia that I think would be useful to you. And I would like to show you the paper, which, just a moment. I would just like to show you the paper which actually told psychotherapy does not work. So what he did, so just to understand what systematic review meta-analysis is. So this is the seminal paper, The Effects of Psychotherapy and Evaluation, which clearly bashed psychotherapy does not work. So I'm not very sure when it was published. It is mostly between either 1940s or 1965. I'm forgetting it. But anyway, So I'll come to the evidence table. So this was the evidence table. So psychotherapy has got two arms. One is psychoanalytic models and another is electric therapies. So he got some 5 studies, and then see, just look at it, how he has categorized it. So the categorization is something like that. If you have 100 participants, he was looking for how many got cured. And then another subcategory was how much, for how many the status is slightly improved. And then not improved. So then he calculated the percentage of percentage of people who got cured, and he just had a addition, simple addition. So you can see at the end here the 44%. It is actually the simple addition and averaging out of the all the study. So this is what he did. There was not a very prominent search strategy. You won't find a search strategy because at that time, um, people would have to mostly lean on journals which are available in their universities, collaborations, etc. But anyway, I'll show you the summary. Yeah, so this is the summary which told a survey was made of reports on the improvement of neurotic patients after psychotherapy, and the results were compared with the best available estimates of recovery. The figure failed to support the hypothesis that psychotherapy facilitates recovery from neurotic disorder. So after this was received on 1952. So after 1952, I guess almost just a minute. I guess almost 20 years passed by, nothing happened. These 20 years, psychotherapy was judged as not useful. Then one PhD student came. So he was also a PhD student. This individual, you must have heard his name. He is G.V. Glass. So he had a special affinity towards psychotherapy. He had this thing, psychotherapy does work. And in one of his interviews, he told, I wanted to take on Hans Eisner and show that he was wrong. And this actually came from a seminar when G.V. Glass went out and batted for psychotherapy, and he actually got some bashing from from Hans Eisner and his peers. So anyway, he's one of the quotes which resonates with me very much is a person without a lively interest in the topic at hand probably has no competence in it either. One must trust the principles. So from this, the meta-analysis emerged. G.V. Glass, as you all know, that he is that he coined the term meta-analysis. And I want to show you the first meta-analysis that he did. So this paper started the foundation of what we call today a meta-analysis. So this is meta-analysis of psychotherapy outcome study. So what he identified that Hans Eisner actually cherry-picked data. So whatever data he thought would be useful for his own result, he cherry-picked them. If you see this particular research article, you will see there is a proper standard search strategy charted out. So he actually went to many of the universities to look for articles, to look for abstracts from his peers also. He collected all the abstracts. And ultimately, here you won't find a forest plot. So the primitive forest plot, how it looks, I will show you. So this is the effect comparison. Okay, so this is how he reported his findings. So this is one of the outcome. And then this is his evidence table. And these are his different findings, like control and intervention. He has charted them out in such a way. So anyway, so this is not for something to learn. So this is how the meta-analysis emerged. And after this, right now, you all know meta-analysis is mushrooming like anything. A well done one can actually have some policy change, have some impact, but a not well done, a non-structured one cannot. So a basics in meta-analysis is very important. So I'll just start with definitions. Everybody, I guess, already know what a meta-analysis is, but still, I'll just, for the sake of freshers, I'll just reiterate it. So simply, meta-analysis stands on 3 words. Number one, you identify. Number two, once you have identified articles, you appraise them. And once you have done appraising it, you synthesize them. Now, why do you do that? You, first of all, you pull in the effect size. You pull in the power of the studies, because one study you have 100 participants, another study you have 120. The more you have studies, the more the sample size increases, the more precision, the more precision gets concentrated. So these are the some very few reasons that you do a meta-analysis, but there is some prerequisite. Number one, a very specific research question. Then you have to have a very specific eligibility criteria. So one of our professors, or many of your professors, you must have heard says one term that is called garbage in, garbage out. So if you put in garbage in your software, ultimately the result will also be a garbage. So it's something quite funny, but so appropriate for meta-analysis. And obviously, the name suggests systematic review, so it has to be systematic. And meta-analysis is just a part of the systematic review. Like young researchers, we all like to see those fancy plots. Once in Art Studio, you do one code and a plot comes, we get very excited. Arey wah. But for me, a systematic review is much more difficult, and till date, I am not able to do a very well done systematic review. You can follow actually the Lancet papers, which are pure systematic reviews. How beautifully they bring in the conflicting methods, they bring in a new framework. Anyway, so meta-analysis is just for pulling your effect size. You have some quantitative outcome, you want to pull it, you want to have a single estimate. Suppose you want to know the anemia prevalence in your a nationalized prevalence you want to know, and you have some sporadic studies across your country available. So you want to pull in the resources, you want to pull in the studies, you want to have a single estimate. You do a meta-analysis. There are many things, I'll just cover it later. Okay, so I'll just reiterate why systematic review is much more important rather than just fixating on meta-analysis. So I'll show you this particular study. So this is another one stalwart paper which showed that low dose computed tomography screening for lung cancer related mortality. I mean, low LDCT is beneficial for screening in lung cancer. So they actually went ahead and showed that there is a 21% mortality reduction with LDCT screening for smokers. If you screen for lung cancer, there is a 21% mortality reduction. And how did they define their outcome? The mortality reduction is defined as the event, that is the occurrence of lung cancer throughout 10 years follow-up. So it is a Cochrane review. And obviously you all know what Cochrane is, and those are like 200 pages reviews, very hard to complete. And okay, so this is the review. Impact of low dose computed tomography screening on lung cancer related mortality. So I'll directly jump to their conclusion section. Say it is a 148-page review. So you actually need to draft all these in RevMan. So sir, are you and your batch, you are using RevMan, or how do you conduct the systematic meta-analysis part?
Redman, you mean?
Yeah, so I
Yeah,
mean, do
yeah.
you conduct in,
I
okay,
think, yeah, they're I think using the Rapeman and Ryan or something like that. Yeah. It is
okay,
each
okay,
group is using, they're free to choose their own softwares, and the tutors are
okay,
taking care of it. Yeah.
okay. So see, they found out around 8 trials, and 8 trials constituted around 90,000 participants. And over 40 years, generally, doctors tell this was the first paper after which this recommendation came that LDCT should be done after 40 years. So yearly once, or in 2, 3 years once. So they showed that it reduced lung cancer death by 21%. So this is the meta-analysis part. So from the 8 trials, they actually found out कि 21% reduction to reduction does happen. And then there are other some quantitative details also, but leave it for now. But why then systematic review is important? You have a 21% reduction, you have already charted out. Then why then you need to review? You need to actually go through all the studies, just not extract for the quantitative details that you need. So let's go to their evidence table. So this is, the grading of systematic review, the grade tool they have used. I'll tell later. Yeah. So this is something which is nodule, which is written as nodule management. Now you screen for lung cancer. What is it that you are finding? What is it you are looking for? You are looking for a nodule, some kind of pathologic changes. Now, when to say that a nodule is pathognomonic or it is of some concern? So one study by Aberil et al. 2011, they told it has to be non-calcified module. It has to be more than or equals to 4 millimeter in size, and they did not have any particular algorithm for management. That's fine. Come to the next study, Baker 2020. They told a positive scan would be any nodule, be it calcified, be it non-calcified. That doesn't matter. Any nodule, but that has to be more than equals 5 millimeter in size. Okay, fine. And they have a treatment algorithm. So if it is less than 5, routine screening would go on. If it is 5 to 7 something, oh, they have an algorithm. Fine. Then next study comes the Blanchon 2007. They also told they told ki non-calcified it has to be, and the size has to be more than 5 millimeter. So not equals to. So see this much heterogeneity, this much variation among the different algorithms. So now I have told you कि भाई analysis we have done, and there is a 21% reduction. But then how do you fix the criteria? If you just do your meta-analysis, how do you fix the criteria? What should be the perfect algorithm? Should I keep non-calcified? Should I keep calcified? Should I keep 4 or should I keep 5? So that is completely a haywire. If you come to the next study, Deconning et al., so they actually have given a 4-stage classification for nodules. One not category 1, nodule category 2, nodule category 3. So they have much granular classification they have given. So these are just one of the picture that I am showing you. Is so much heterogeneity, so much variation among methodologies, so much variation among population. So everything is there. So these has to be accounted by a well-done systematic review. You can't fix your algorithm with just outright saying ki 21% reduction is there. So it's a gold standard. You can start screening. So these things will come from a systematic review. And obviously you cannot quantify them. Algorithm you can't quantify. You ultimately have to fix this criteria particular we have to have, then only we will further it for screening or something. So this is one small reason why please learn systematic review, please learn writing. The narrative synthesis part is as important as it is than just doing a meta-analysis. So there are some other problems also. Obviously, risk of bias is there that a meta-analysis don't tell you. Overdiagnosis is a problem for this particular article. Then in between something happened, like one study by Nelson, that categorized study. So what they did was they switched to death certificates. Death certificate means for counting the events, they switched to death certificates. So that is a bias. So that is instilling bias. So all these things you have to be very careful of. And then obviously long-term harms beyond mortality. Like 21 is a quantitative details. It does not catch the perception of your patient. It does not catch the perception of how things getting unfold. So they actually saw from the qualitative literature review that it does reduce the anxiety. Obviously, if you are having a screening and a negative result, obviously boosts your morale. And then many people saw that at a very early stage, or maybe not even, it is actually helping in cancer or tobacco cessation. So there are people who are actually leaving cigarette, quitting cigarette due to this early screening. So all this data will come from a well done qualitative synthesis, well done systematic review, not a meta-analysis. So please remember, do a well done review. Please go through the whole article very well, and don't obviously use AI tools. Those are super helpful, but make it like your slave, not a academic senior or something. Okay, so this is just systematic review and meta-analysis, how it is different. In the left, you are seeing uh, the four parts of puzzle are similar enough to be combined. So you do a meta-analysis, and the right part, they are not similar. That means you cannot do a meta-analysis, but yeah, systematic review is possible. So anyway. Okay, so this is for freshers. Many experts will be there, and this is mainly for freshers. So suppose, so at the very first, when I started learning meta-analysis, one of my cousin asked me, I showed him the very first article that I published. After that, I showed my cousin, "Today I have published a meta-analysis in this journal." Okay, okay. So I told there were 5-7 studies. I pulled the measured. So here, suppose we have 3 studies, study A, B, C, and they are measuring the effect of a drug in terms of some kind of risk reduction. Anything you take. So he asked me, my cousin asked me, why can't we do a simple average? So till now the question was easy. We can just simply average it out, 0.80 plus 0.90 plus 0.70. We'll divide it by 3. We will have 0.80. Then the relative risk reduction would be 1 minus risk ratio. That is 20% risk reduction. Can that be my answer? Obviously, no. This is very easy because we are not accounting for the sample size variation. Because the more the sample size, like the study B, would be given undue weightage because of its sample size. So we can't do that. Then he asked me, okay, we can do weighted average. Then weighted average, why is that we have to do a meta-analysis? What about weighted average? So what weighted average do is simple. So and we'll just count out the sample size. We will add that. So study A, the weighted average result would be 100 into 0.80 by 500. So similarly, we will add the next studies. So is that a plausible thing? Is Can participant interact, sir?
Yes, certainly. We can have a participant interaction now. Participant, those who
Okay.
want to ask any question to Dr. Rounik, please put it in the question and answer. I should have announced that in the beginning. Please keep on asking questions as he goes on presenting the topic. Right now is the point when you can ask question directly, or you can put the questions in the question and answer, and we'll read it out for you. Whichever medium you prefer. Okay, you can raise hand and we'll allow you to speak. Okay, and we'll enable that, or you can put your question in the question and answer, which is the easiest. Okay, yeah, so go ahead, quick.
Okay. So here the question is, why can't we just get it done with a weighted average? What's the problem in that? Even in meta-analysis also, in most simplistic term, there are some weighted averages involved. Weighted averaging, if you see the mathematics beyond the meta-analysis, there are weighted average, that is a step is there. So why is it not, why it is not enough? Can anyone just say, look at the confidence intervals, just say, can anyone?
Okay, Dr. Talukdar is our question, please that in the chat. Okay, Faisal, please allow all the participants to respond in the chat. Okay, yeah, open the charts as well as the questions. Done it, Faisal? Okay. Okay, okay. Now it's open to everyone, so you can put it in the chat, the answer to Dr. Talukdar's question. And if you have any questions in particular, you can come back later, but keep on asking questions in the questions so that we'll take them. We'll take a break in between and we'll ask a few questions to Dr. Talukdar, then he'll resume again. So the same standard format that we generally follow. Okay. Yeah. Okay. Have. Okay. What have?
Okay. So I think we should move, right?
Yeah, Arindam Mishras is saying sample sizes are different, so each study will give a different weightage.
Yeah,
Means
that
we will
is
have.
taken care of by weighted average, right? Simple average may there is a problem with sample size being different. That is why you are doing weighted average. Obviously, the more the sample size, it will have some more weight, right? So that is obvious. So that is why you are doing, but you are giving equal, not giving equal weightage. In simple average, every study is getting equal weightage, and the problem is the outcome will be suffering from that. But here, um, weighted
Two
average में तो
other
सही है. It's
two other people are saying Malati is saying confidence interval is high if sample size is low, and Anisha Datta is saying different weightage because different sample size, and Samima is saying definitely.
okay. So I'll just go ahead. The thing is, yes, obviously, all you have or whatever you are saying is correct only. But the thing is, whatever you have saying till now, we have done weighted average for that. Weighted average takes care of the variance in sample size, but it does not take care of the precision. There are variability among the studies, so it does not take care of the precision. I'll just show you one thing. See, if you when you do the meta analysis, in suppose this study I have used the inverse variance weight. I'll tell what that is later. So here the study B ultimately end up having more weightage, because see the confidence interval of the study B, it is 0.85 to 0.95. It is very constrained, so obviously this study, in spite of having a larger sample size, will get much more weightage. If you do the simple weighted average, that won't happen. Whatever the sample size is, proportional to that, that much weightage would be given to study B. But actually, in meta-analysis, we will give more weightage to this particular study B. So that is the thing. And it is not like that key low sample size means wide confidence interval. It can be, it generally is, but not always. Larger the sample size, more power, more precision, yeah, obviously, but not always. So anyway, we'll shift. Then I'll tell you some pitfalls in study selection. So what is it? Suppose in right side you can see a study. It's a very simple study. So we wanted to see the tobacco usage pattern in India. I mean the status of tobacco usage in India, and we drawn the evidence from 2010 to 2022. So our primary objective was to estimate the current tobacco usage among Indian adults by drawing information from regional and pan-India studies published between 2010 and 2022. Acha, one of the participant was asking when should we do a systematic review meta-analysis. Suppose in your clinic or in your hospital, um, you are hearing now and then there is a new drug or there is a new kind of surgery that has come with a improved outcome, but you don't know that will if that will work on your population. The studies may have been done in outside, the studies may have been done in your state, the studies may have been done in your nation, but it is sporadic. You don't know ki where exactly in your college, exactly in your clinic, exactly the catchment area of your university this will work or not. So at this point of time, if you want to have a pooled analysis, so you are basically pooling all the sample sizes from the different studies available. You are accounting for the heterogeneity that exists between the studies. So there will be variability, right? Heterogeneity means right now just think it is a variability among study participant. They are different. The interventions, there may be a little difference between studies. Then outcome can be different. So all this variability would be taken care of by the meta-analysis. So you will have a result. What you can be sure of, ki, with some extent within a range, our new drug or our new intervention may work. And instead of that, those 10 effect sizes, instead of those 10 single measure, now you have a single point prevalence, single pooled prevalence or pooled estimate, which you can infer for a larger population. So that is why you do a meta-analysis. Suppose, see, in a policy agenda of your government, when he or she is trying to, like anemia Mukta Bharat. So these dosage changes are happening every now and then, every 2 years. So what do you think? When in a 30 minutes policy agenda setup meeting, they will come and go through all the 1,000 studies that have been published? Not possible. They will rely on one systematic review, a well done one, obviously. So that is the basics of very primal basic of why you do a systematic review meta-analysis. It actually do bring in policy changes. I'll show you later. But anyway, let's concentrate here. We wanted to understand what is the tobacco usage estimate among Indian adults and leave out the secondary objective. Now I'll show you four studies, and you have to tell me. I won't tell you the selection criteria. I just won't tell you. The objective is the current tobacco usage among Indian adults. I want to know the pan India estimate. So let's go to the study one. You have to tell me, should I include this study or not? My PPT is hanging. I don't know why.
It's okay. Don't worry. Okay, participant, when Dr. Talukdar asks any question, please respond to that in the chat. We have opened the chat as well as the questions for you. But please ask the questions in the Q&A and put the comments in the chat so that it doesn't get lost. Okay, remember this. Okay, some people are asking questions regarding attendance. Let me respond to that. The attendance is auto monitored by the Zoom Premium. So we have when time, what is the time you joined, what is the time you left. We have records for that. Remember this. We have logs. In addition, we'll be also taking your attendance through an attendance feedback form at the end. So please remain patient. Focus on the learning. Don't worry about the certificate. Thank you.
Just allow me a minute. There, I may have encountered some problem.
No problem. You're dealing with many softwares, so it can be difficult to navigate all that. Okay. Somebody is saying, but an increase in sample size should increase precision as well. Why is it different from the study you just shown?
Yes, of course. As you increase sample size, it obviously increases the precision. But the study I have shown, like this one, right? The examples, the three studies. Here, you are essentially pulling the main estimate, pulling the effect size. Now you have three studies. So in each study, there are particular point estimate, particular mean or something, a difference, and a corresponding confidence interval. Now see, study A is a very wide I mean confidence interval. Study B is a very short size. Now ultimately what you are doing, you are having one meta-analysis that is a pooled estimate. It will of course have a very precise estimate that is there, but that does not tell about which study would be weighted more. The study B would be weighted more because study B was much precision was much more. You can see, right? It had 500 sample size, and obviously it had same precision was much higher, and it is a well done study. But I told ki it is a general thing. Ki rule of thumb you can say ki the more the sample size, the more the precision. But it may not be always true. That is what I am saying. Obviously, the more the sample size, the more the precision. Think this link is not working. I will rather just tell you three scenarios and you have to tell us some problem has happened. So leave it.
You can do one thing, Rounik. You can stop it, like escape it, and then it will probably improve.
Yes. Okay. Okay. So rather making you tell this, I'll just directly tell what you should not do when selecting a study. You have seen the objective. I want to I want to know the estimate, the current tobacco usage estimate among Indian adults. Now, suppose study one, there is a study that is done among um, maybe in a prison. So among the prison workers, it's a multi-center study. So it has involved prisoners from all over India. So what do you think? You should include that study. It is exactly assessing what we want, the uh, tobacco usage prevalence among Indian adults. So what do you think? Do we include this study?
Please put the response in the chat quick. Please be quick. You're all here to
Yeah,
learn. Please
exactly.
focus on learning. Respond to Dr. Talukdar. No, yes, yes, no. Okay, yes. Okay, yes. Let's see.
Okay, so mostly no, and obviously we won't be including the study. Why not? It is of course always to start with. It is a biased population, so you have to have a very like see one thing is generalizability of your population. That means whatever outcome you are getting from your study, that outcome should be generalizable to the broader population. Similarly, I have seen many, even senior researchers. Just last 2 3 days back, I got a study from very reputed journals. So they went ahead with vitamin D prevalence analysis in the global scenario, and they have included. They wanted to know the vitamin D status in under 5 children, and they have included studies which are primarily done in an institutional setup. So now many people says many thing about this, like a well done study which are conducted among maybe among 80 schools across India, and or 80 maybe health facilities across India. Is that something we should take? We must not. If at all you want to take those studies, have a subgroup, and don't tell in your title ki we are aiming for this. You tell whatever literature you have, you are going for an analysis. You want to present the subgroup analysis also. So any study that is done in an institutional setup or a facility-based setup, or maybe in a prison, maybe in a particular, or participants who are having some particular comorbidities, or maybe studies which have preliminarily looked for association, but they have presented this tobacco usage estimate. So there are, I mean, conflict also. There may people may say ki they have a sample size, their objective was correct, so we can use that. Many people say that, but what I feel and what I have studied through, their to start with, their objective was different. Their sample size was adequately powered to find out the association between exposure outcome, not the prevalence. So maybe we can have in grade something is there called optimum sample size. So if we can attain at something like that, what is an optimal sample size, and the sampling unit is not biased itself. So suppose you are recruiting only people with comorbidities to look for the association or something, then maybe we can think of taking that, but still there is some bias to start with. Okay, so this everyone knows. For the freshers out there, when you do a literature review, you start obviously with the idea. Without idea, nothing can be done. And then you define your research question. Then you do a thorough search. Once you searched, you may find out, you may stumble upon 10,000 articles. Everything cannot be a fit with your objective. You conduct screening, then you extract data, then you have the quality assessment done. Then ultimately you do your statistical analysis for meta-analysis, or if not, then narrative synthesis, and then you report. So this is just a chart how to go about meta-analysis or systematic review. So this is also very trivial. You guys would be knowing this. So idea, why I keep this, it's a very primitive or preliminary thing in research, but I like it. So everyone knows about finer. So feasible, the idea has to be feasible, interesting. The idea has to be feasible, interesting, novel, ethical, and relevant. Um, Now, novelty does not always means innovative, completely new. Novelty is kind of a very vague term. Can you do a meta-analysis with a systematic review? Yes, meta-analysis is a part of systematic review. If you can find out enough studies, enough outcomes which are almost similar with some variability among them, you can do meta-analysis. Meta-analysis is a part. So there are studies specifically in China, they just do meta-analysis. They will outright write key meta-analysis and they don't even go for narrative synthesis. That is also being done. But yes, systematic review, a well done one, followed by a meta-analysis is always appreciable. But if you are just doing the meta-analysis also, I mean, this is research, right? So nothing is wrong until you can back it up with logic. It's like that. So anyway, novelty is a very vague term. Same study, different location, you can tell it is novel. In-depth review of pre-existing literature, a scoping review, which will ultimately find out something very novel, can be novel. Relevance is also a very tricky term. So relevance is number one, maybe staying scientifically relevant and versus staying societally relevant. So I'll just show you one picture. So this is a AI generated picture, a very badly generated picture. I don't know what is there in the screen, but just think this is a rural setup in a very remote place, and there's a hi-fi screening device in front, and one is supposed to be a patient, but both are wearing apron anyway. So one of them is a patient, and one of them is our Asha Didi or sister, someone, or a doctor maybe. So scientific relevant is building that machine. So you are training the AI tools, you are training the algorithms. So all those comes under the scientific phase. But here, till the time that scientific phase has gone to such kind of rural setup, ultimately being useful to society, I don't think that would be regarded as societally relevant. Then again, there are many school of thoughts. People will say, why do I have to do like that only? In urban areas, if it is implemented well, then also it is societally relevant. So this is a debate. So let's not go there. But yeah, so relevance have very shades, its own shades of difference. Uh, anyway, so I'll just skip. Question format you all know, Pico, everyone knows. I'll directly, so this is how you frame a very basic question. Some intervention you have, a population you have, a comparison arm you have, and then you have an outcome. With all this, you can actually frame a research question. So like a question example is given, does the administration of a pentavalent rotavirus vaccine significantly reduce the incidence and severity of rotavirus gastroenteritis in Indian infants while compared to a placebo? So, see, the population here is obviously Indian infants. Intervention is the vaccine. Comparator maybe there, may not be there. Here it's a placebo, and outcome is the reduction in gastroenteritis. Now, what is important is most of you know PICO. The important thing is what are the disadvantages of PICO. So, PICO is not suitable for qualitative research. Research with when you want to know the perception of people, Pico fails miserably. It is not very flexible. The things are very restricted in Pico framework. So in place of Pico, there are many things that have come. So this is another format for condition based meta-analysis, mostly for prevalence or proportional meta-analysis, which are in rise like anything now. So this is Coco Pop. One is condition, one is context, one is population. Condition is what is the prevalence of dementia in rural areas of Pondicherry, India. So condition is dementia. Context is can be socio-economical context, can be geographical context, can be anything, and population is there. So just refining the question, what is the prevalence of Alzheimer's disease among individuals aged 60 and above in the rural districts of Pondicherry, India? You are just making sure the age group is there. The research question is much more stable, much more solid. So come to another one. This is called SPICE. So that Indian spice is there. So this is SPICE. So S starts with setting. So where is this taking place? Perspective. Whose perspective you are interested in? The intervention, it's there. Comparison, it's there. And then the evaluation component. Okay, so someone is hearing Coco Pop for the first time. It's cool. Everyone hears something first time only. So you can actually draft a research question using Coco Pop and all these. These are there in. I'll send you. I'll send Professor Satpathy the links. He will share with you guys. But just so spice is something which are useful for research question where outcome of a project, a program, or some service is evaluated. Okay. So I'll give you a scenario, and through that I'll make you understand what spice is and how with spice you can build a research question.
Okay,
So
just a second, Rounik. Okay,
yeah,
participant, please ask the questions in the Q&A section only, not in the webinar chat, because it gets lost among hundreds of responses. So if you do not want us to read your questions or respond to them, then it's fine. Otherwise, you can put the questions in the Q&A section only. Okay, moving forward, I am repeating, please put your questions in the Q&A section only, not in the chat. You can put the comments in the chats. Okay, that's all. Thank you. Yes, Lord. Thank you.
so to start with, which research question framework to use when? PCOT is something which is used mostly for intervention studies. When you have, I told PCOT is very not flexible. So you have an intervention, you have a comparator, you have a population to start with. It's a trial, and you can frame your question through PCOT. For COCOPOP, it is specific, very specific for prevalence-based studies. So what is the prevalence of something in somewhere? So like that, the context has to be there, the condition has to be there, and the population has to be there. And then spice and all, I'll just go on and tell you. So here is the scenario. So there are evidence that common mental disorder has been highly prevalent among patients with chronic illness. Everybody knows that, right? So suppose in a community health center of rural Tamil Nadu, Tamil Nadu is a state in India. It's a southern state of India. Suppose a public health specialist want to start a social support group to address this issue of self-esteem and depressive symptoms among the patients in a pilot mode. So now help this community medical officer or public health specialist to build a research question. Now, generally, I give people time to do this, but I guess I'll just move quickly. So the question with the spice framework would be something like this. So what is the effect of a social support group intervention compared to no intervention on self-esteem and depressive symptoms? So the evaluation is self-esteem and depressive symptom in individuals with chronic illness at a community health center in rural Tamil Nadu. Once you identify the each of the things like what is S, what is a setting, what is the intervention, what is the perspective, what is the comparator, what is the evaluation, then it is very easy to draft a question. So just keep these things in mind. Spice, so S, P, I, C, E, identify that you have your question in front of you. Anything. So there is another thing which is called spider. So spider is also used mainly in qualitative studies. So spider is unique. So spider builds what? Spider builds a web or net. So here through spider framework, you can actually interweb many questions. So you have two, three questions, you can web them, you can join them. So it is mainly for researches which look about attitude and experience. Suppose S for here is sample. It describes the group you are focusing on. So here, suppose one example, these are high school students. Then there is PI, the phenomenon of interest. What is the problem? What is the phenomenon that you are interested in to research? So this is basically the behavior or experience your research is examining. So that is social media usage. Social media usage among high school students. Now you come in the design. What was the research? Like what would be the design? It can be interview, can be survey, can be content analysis, anything. And then what is it that you are looking for? What is the evaluation matrix? The evaluation matrix would actually be the perception and attitude towards social media. And research type can be mixed method, can be qualitative or whatever. So the question would be crafted like, how do high school students perceive and experience social media usage? This is one question. And how does it impact their attitude towards it? So this is the second part of the question. So basically, you are conjoining two questions with each other. Mm, Can this be two different questions? Yes, that can be, but this is more efficient because ultimately the attitude follows the experience. So that is why. So this is another framework. Just later go through all this. You will have a much better understanding. I'll quickly just go through this. Here, basically, difference between it is again for freshers. So, what is scoping review? What I like to remember is, yes, of course, interview is a qualitative method, not a research design. This is how you administer a method. So, it is not a research design. So, anyway, so how do you do it? The interview, do you do through interview, survey, or content analysis? It comes under the design part. Yeah, you rightly have pointed out. This is a research method, not a design. So anyway, so what I like to remember is scoping review. You map, you gap, you inform. So you map the literature, you find the gap, then you inform the audience what is new, what can be the new angle, what can future hold, something like that. So suppose there is something, a topic like impact of social media on mental health, the association between social media use and self-esteem. So a narrative literature review ultimately will summarize everything. It will present a balanced view between two conflicting evidence, and it do not go out and outright start critically assessing them. So there are two opinions. Like a good journalist, it will have both of them in front of you, and it will let the audience decide what is what. So it is a summarization, majorly a summarization. A critical review goes through the methodological nuances. So it will highlight the inconsistencies in the findings. It will discuss many possible reasons for the mixed conflicting findings. And a systematic review, you already know. A scoping review, on the other hand, on the same topic, may find something like there is lack of research exploring the intersection of social media, mental health, and marginalized population. So this is the research gap, and it has informed a new research area. So that is what is a scoping review. Okay, so scoping review find a scope. Like a telescope, it finds a scope between the mapped literature, in the mapped literature. So anyway, this is something very quickly. And in scoping review, one thing is coming up by Campbell collaboration, which is called evidence gap map, I guess, EGM. So you can go and have a look at that. You can effectively very well find out gaps and literature through that. So it is like a Cochrane Revman. So if you register the title or a protocol through them, they will hand you out the EGM, evidence gap map software to you. I mean the web portal. You can work in that. It's a beautiful thing, quite fancy and powerful also. You can have a look at that evidence gap map. So coming to the literature search, there are two kinds of literature. You all know, one published, one gray. Gray can be found all these things in all these portals. There is something called GrayNet International. So so you can found all this here also. Under GrayNet International, you can find PubGray, you can find publishing literature, and then you can find many other directories also. So you can actually go about different directories in here. And so coming to this, so if you see, look at PubMed, there are many things. One is PubMed, one is Medline, one is PubMed Central, one is Medicine Plus. So the very core component is Medline. So Medline does have about 23 million reference. It is updated till last year. Now, obviously, it would be increased. So Medline is the core thing. Then comes the PubMed. So PubMed essentially is a search engine. It is a way to access Medline database. And PubMed also have its own some repositories also. And then comes the PubMed Central. PubMed Central is the full text repository. So it overlaps between Medline, PubMed, and some of the articles which may not be there in PubMed or Medline, but you will find them in PubMed Central. I actually get surprised how this indexing works. Many of the journals from Iran, I have seen ki, so many of the journals in Iran, I have seen they are registered very quickly in PubMed Central, like maybe in a 6 months or in a year. But ultimately, after 10 years, 15 years also, they won't be included in Medline. Medline, the quality standard is a little more, the benchmark is a little more, and PubMed is after that, and then PubMed Central. Anyway, just trivial facts. Then which database, which when to use? There is something you would be knowing, Amstar guidelines. It tells key at least two database you need to include when you are doing a systematic review. But the more the merrier. But it doesn't mean key whatever you find, whatever database you find, you include them. So PubMed is basically the biomedical repository. Embase is there. Embase actually covers the allied health aspects, pharmacovigilance, pharmacy related, like health technology assessment research. You can't do without MS. Scopus again is a very multidisciplinary database. Most of the social sciences topic, political sciences topic, the conglomeration of social science, physical science, health sciences you would find in here in Scopus. And then there comes Sinahal. Sinahal mainly covers almost 50 to 60 nursing specialties. There would be dietetics, there would be nutrition, there would be physical therapy. So whenever you are whenever you are choosing any of the um, databases, keep in mind all these things, which one you should at least have. So you can have a rule of thumb key, at least PubMed, Embase, Scopus must, and then please don't do Google Scholar. That is just an engine, search engine, and don't write even Google Scholar. Okay, so how to do PubMed search? This is something which is called mesh library. Again, I won't be clicking the link because it's getting hanged. Just whenever you try to start a new search strategy, first don't start outright in the PubMed Advanced tab. First, have a look at Google Scholar, normal Google key, what are the synonymous terms, what are the very terms that can be available, and go to something called Mesh Library. So Mesh Library will have index terms which PubMed has indexed. So coin out all the index term that can be applicable to your research like this. So this is something looks like this. So see, there are some options like if you search chronic kidney disease here, you can search the full word, you can search for an exact match, you can search all fragment, you can search any of the fragment. So mainly try to look for exact match. And if it is a very niche or new topic, or maybe something like maybe bereavement in coping after a death of a new one, your loved one. So grief, stages of grief will come. So bereavement, coping, these are the terms won't be here. So maybe look for fragments among them, coping strategy or something like that. Maybe look for fragments, but mostly for chronic kidney disease, try to look for exact match or all fragment. So if you search here chronic kidney disease, something like this will come. Now see, they have given a mesh heading. So in the mesh heading, you will get the index term, which is renal insufficiency, chronic. And you should see the entry terms in here. The entry term are the terms that you must have in your search strategy. It may look weird, but trust me, having these terms, maybe repetitions are there. You may think, Are, these are same, why do? But it's best to have these rather than having all other truckload of terms under title abstract. So have these terms under mesh term. It may not be under mesh major topic, but either it will come under mesh subheading or under other terms. There is another thing in advanced PubMed tab. If you go, there will be things like other terms. So choose under that. So at least this term has to be there. Okay, so now for freshers again, many of you get confused with the Boolean operator and or. So I would like to remember this with the tea coffee example. So suppose you have gone to a restaurant and the attendant has come to you and he or she has asked that, sir, ma'am, what would you like to have? And you reply, I want to have tea or coffee. won't he be confused? So getting confused, if he's a very shy one, so either he will bring tea, or he can also bring coffee, or if he is super confused, he can bring tea and coffee both. So this is what PubMed gets confused. If you use or as a Boolean operator, PubMed will bring you either tea or the articles that have tea in them, articles that have coffee in them, and articles that have both these terms in them. Like here, see, I am just using the title. I am just instructing PubMed. He find me tea or coffee, and I want to look it in just in the title. So see, in the first, he has come out with tea. In the second, tea. In the third, coffee. So that's what. Yeah, plus sign is also fine. And then there comes and. So here, what is happening? Same thing. The restaurant attendant or waiter or waitress came, and you told, I want tea and coffee. Obviously, he or she will be bringing tea and coffee both. The same thing. You instruct PubMed. Yeah, I want tea and coffee. So PubMed will bring you articles that have tea and coffee both in them. So this is just how to remember Boolean operators. There is another one, not, that is very easy. Suppose you want to include all kinds of coffee, all kinds of tea, but not Darjeeling tea. So you can actually go ahead and write not Darjeeling tea in title. So it will scrap out all the articles which will have Darjeeling tea in them.
Okay, Ronik, can we have
Yeah,
a
sir.
quick round of questions right now?
Yeah,
Because
yeah, sure,
we have
sure.
just
Yeah.
completed 1 hour. Okay, okay.
Okay.
Participants, please put your questions in the question Q&A tab. I'm questions. I'm going to read out some of them so that Dr. Ronik can have a go at them. Okay. Right. Okay. Chandrima Das is asking what all conditions would be considered while selecting any specific framework.
Okay. So regarding the framework, as I told, look at your research question, look at your idea. If it is a trial, you can go. If it is a trial and direct head on head comparison, you are not looking for anything else, then go for PCOT. Because as I was saying, PCOT is not very flexible. So drug A versus drug B, intervention versus another comparator or another intervention, head on head comparison, so just go for PCOT. Then spice, spider, all those things. Suppose there are, okay, so suppose there is something key, there is an intervention you have administered, some oral cholera vaccine, new cholera vaccine have come. Now if you know that Sancol is one cholera vaccine and it has a fishy odor, so if you have it, it is a oral cholera vaccine. If you have it, it has a weird fishy odor, like much, I mean, fish you are, if you are consuming, it has a very typical weird odor. And for that, that was one of the reason why people doesn't want to take that. And this particular thing also came up in studies. So you want to know the perspective and the drivers why people are not taking the vaccine. So in such kind of research, where you want to see the attitude, the drivers, the facilitators, the perspectives of a participant, of your participant, then you have to look for frameworks other than PCOT. Because see, in PCOT, nowhere you can fit in perspective, nowhere you can fit in emotion. So you can fit in all these things under spider, under spice. So there is no hard and fast rule. Look at your research question and look at the frameworks where it fits, it fits. That's all. There is no algorithm. This one is here, click, 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 it will go directly there. There's nothing like that. Just look to your question and look to the research framework. Whatever fits, it fits. I hope I answer your question.
Yes, you certainly did. Okay, Anisha Datta is asking, sir, when to decide whether or not systematic review is needed or some particular topic, on some particular
Yeah,
topic.
yeah. I think I have already answered this. I saw this question before. A guy was saying you have like 100 studies, but you want to have a pooled estimate. You don't have pooled estimate as such. Like we did a study on chronic kidney disease prevalence. The problem with chronic kidney disease prevalence is, number one, you can declare someone is having chronic kidney disease, with two consecutive tests. Like today, if I test, after 3 months, I have to confirm it. Then only I can say this is chronic kidney disease. Whether you use EGFR as a criteria or other standard set criteria. And most of the studies do not do that. They don't. Obviously, after a 3 months follow up for such many participants is logistically not feasible. And most of the cases of chronic kidney disease study are done in voluntary camp mode. So here and there would be camp set up. So it is a very problematic for us to curate data. And there is still date, instead of some multi-cohort study, there are no solid chronic kidney disease burden available in India. So our study was one of the first study, and it was even covered in India Today and other leading journals, The Hindu, as the first one to come up with a prevalence estimate, pooled prevalence estimate across India. So we also took the camp mode studies, and we actually designed something called optimum sample size. So in a camp mode, obviously it's a biased population, right? A camp mode study you cannot take for a generalizable estimate. But we devised something. I'm not very sure if that is a very correct way to till date, but yeah, it got published somehow. So optimum sample size, we used something like there has to be minimum this much response rate from the catchment area. So we actually went ahead and saw where the study got conducted. If the population of that area is this much, how much percentage came for the camp? What was the division of age group in the camps? So we look for if all the age groups were there or not. So many of these things. So these are the something when you do a systematic review.
Okay, the next question is from Jusu Musha from Sierra Leone. He's asking, when is it appropriate to conduct a meta-analysis?
Okay, so I guess it will come. And a meta-analysis is appropriate to conduct when there are just, remember, there are similar quantitative estimates outcome available. So again, drug A, drug B, head-on comparison, you have a effect size. Now 3-4 studies, similar effect size is available, and the population intervention is almost similar with some variability. Then you can have a pooled estimate or meta-analysis. So meta-analysis is possible when there is almost homogeneous to certain variability things are available, outcomes are available. So then it is appropriate to conduct. Certain variability are accounted for with heterogeneity, subgroup analysis, and many other things. But if it is outright very much variable, population itself is very different, intervention itself is very different, then you should not. Then you actually should nicely synthesize it narrative way in a narrative way.
Okay, the next question is from Raymond Chetri from Nepal. He asks, how do you ensure the search strategy captures all relevant studies, especially unpublished or grey literature?
Okay, so see, first of all, have your research question ready. Second is put your research question classified under one of the research framework. Now identify concept. Look for their Singapore University, National University of Singapore. If you go there, NUS website, just write NUS systematic review search template. So they actually provide a tabular format where you would put in your search strategy. You identify concept one, concept two, concept three. So one concept may be tobacco usage in Indian adults. So one concept is tobacco, one concept is prevalence, one concept may be lower middle income country and India. So clearly identify these concepts, sub-concepts, and under one concept you have all your synonymous terms, another concept have all your synonymous terms, another concept. Then you build your search strategy, you search and everything. And after that, what you can do right now actually, for snowballing and all, I mean snowballing means the literature, the reference chasing. So you have identified suppose 10 articles. So from the article reference, you can either manually chase them, or what you can do is there are things like litmap or research rabbit. You can upload the 12 article in your litmap research rabbit. It will do the reference chasing by themselves. The paid version, if it is not available, the free version, um, at a time it allows you for 20 iterations. So you can multiple time you can do that, and then you can use all these things.
Okay.
So this is what.
Yeah. Okay. Uh, right. Okay. Good. Jakaria Audu is asking, is there a free software tool for these analysis?
Sorry, sir.
Is there a free tool for analysis?
Yes, of course. There are many right now. Right now, see, Art Studio where I do, Art Studio is completely free and forever it would be free. Yeah, one thing is that Art Studio learning curve is a little steep. But if you can start, it's a wonderful software. Right now, I don't know everything in Art Studio. So whatever I need, I learn it. So you can take that approach, and like n number of website, n number of materials are available to teach you learn Art Studio. Go to Coursera, audit freely a particular course, maybe from John Hopkins or something. They have Art Studio courses, audit them freely. You can do that. Then Jamovi is free, but the outputs are very rudimentary in Jamovi. Um, then JASP is there. JASP is free, but in JASP also again the output is very rudimentary. And then Excel based softwares are there, right? So Excel based softwares would be like Meta Excel is there, Meta Essential Excel package is there. So Meta Essential to bahut hi, it's like very easy. So you have to just put in your data, it will automatically flood all the Excel sheet with all your outputs. The thing is, see, doing meta analysis right now is very easy, but just please have the backbone of your review solid. That is the one thing that decides the eligibility criteria. Have your protocol very well reviewed by people. Nowadays, the problem is Prospero does not check protocols. They only check protocols which are very related to COVID. You 15 days you get a Prospero registration. So it's whatever, whenever you want, you do a meta analysis. So always don't go solo. Have a expert in your team. That's all.
Okay, Rounik, now you can continue your presentation and we'll do another round of the questions at the end of your presentation.
Okay.
And please feel free to give them a demo of how you are doing that as well,
Yeah.
so that because they're asking for practicals.
Okay. So this is how the search string looks. I told you ki you have to categorize your searches in a box. Like I used here the Coco Pop approach. So the condition would be this. Ekdam explicitly write things like this in your um, Word or LaTeX, whatever you are using, and then identify synonymous terms, identify PubMed terms, and everything. This is a very rudimentary snapshot that I have provided, but yeah, it serves the purpose. Then go to the advanced tab, and your ultimately search strategy looks something like this. Okay, so there is something which is new in PubMed. It has come maybe last 5 years. That is proximity operator. So it works something like this. There are two different words. So one word is tobacco and another word is meta-analysis. And you are instructing PubMed, I want these two words, suppose in a title, within a total of 7 words. So how does that work? So you have to exactly write this in a quotation, tobacco meta-analysis to a title abstract, and then what is that sign? I don't know, some sign, and then 7 or 8 or 2 or 3, whatever it is. So essentially, you are telling PubMed to find out these two words, and then these two words has to be sparsed in between 8 words. Like in the first scenario, yeah, the sign is called tilde. Okay, thank you. In the second is like that. I mean, it's not of that much use, but yeah, it is there. Then hip pain, and we have instructed PubMed to find hip pain within 2 words. So see, all the hip pain is within 2 words. Pain around the hip within 2 words. Hip groin pain within 2 words. It's like that. So something nice. Okay, coming to Ryan. So most of you know the screening through Ryan. So Ryan is a systematic review management software. So freely you can have three systematic reviews getting conducted continuously at a time, three or four, I guess, if I am not wrong. And the paid version right now is much better. So they do all those Prisma and everything. They chart out by themselves. Duplicate removal, like it's a pain to remove duplicate in Ryan or in other software when it is free, but paid version detects automatically. You can set up a thing that cutoff value. Over that, it will automatically detect the duplicates and delete them. So Ryan looks something like this. Once you comes within the Ryan portal, it looks something like this. And here under the new, yes, see, yeah, exactly. Covidence is very useful, but I find Covidence too laggy. I mean, I have used Covidence, but then I have left it. I find it too laggy and too much messy. I don't like the. I mean, what do they call the portal? Visually, the portal is not that appealing. Is that what I find? I find Kadima much better, I guess. Uh, but anyway, Kadima is also free for two or three reviews, I guess. Anyway, UI, right? User interface. Okay, so you have to go to the new review and then you can register your review. And once you import all the articles, all your reference articles inside Ryan, you would find something like this. I should have nudged the names, but it's already there anyway. So here, see, under Ryan, there it would be showing articles like this one by one. So once you are on one particular article, it will show you three different tab: one exclude, and exclude, one include, and one maybe. So you just go ahead and click if it is something which fits your objective or fits your criteria. You have to click include. If not, you have to click exclude. And if you are not very sure, then you have to click maybe. Then there are options for PDF full text. Once this grading is done, there would be disagreements. On the left hand side, you will see there would be inclusion decisions, undecided, maybe included, conflict. So once the primary screening is done, this is Ryan. This is Ryan software, Ananya. Ryan, it's a portal, systematic review manager software. So anyway, on the left hand side, there are conflicts. So suppose maybe after the screening is done by two independent researchers, then you would go to conflict and you will obviously be seeing some conflicts. I may say include, someone else may say no, it has to be excluded. So you have to kind of resolve all those conflicts. Once once that is done, you will come to full text screening. You can upload full text and you go for a full text screening. So these are very intuitive. Once you inside the software, you would be it's very easy. There's nothing to actually show too much. You just explore the software. It's not that hard. Okay, so coming to a very important topic in meta-analysis. So what do we pool? So from morning we are saying key pooling something. So what do we pool? What we pool is called effect size. So what is effect size? Suppose there is drug A, drug B, and it is working on hypertension. Drug B is a new drug. It is reducing the hypertension by 10 millimeter Hg, and drug A is a old drug which is reducing hypertension by maybe 7 millimeter Hg. So the effect size is the difference, 10 minus 7. It is so easy because the scale is same. Both are measured in millimeter Hg. That's why you can attain something called Ross mean difference, RMD, because the scales are same. Both are measured in millimeter Hg. So why p-value is something which is very messy between statistical and clinical significance. A clinically significant study may be not statistically significant because the sample size is low. So p-value cannot be estimate that can be used. It is much influenced by sample size. Whether effect size is not that much influenced by sample size, and effect size gives you a magnitude of effect, the direction and magnitude, how the effect. It is large, is it large, is it small? So that is not provided by a p-value. So yeah, advantages of effect size: it is independent of sample size, it measures the extent of treatment effect. And okay, yeah, definition, leave it. Okay, as I was telling, the raw mean difference. So group A, one mean mean of maybe blood pressure drop, mean drop of blood pressure. In group B, mean drop of blood pressure 2. So simple RMD, raw mean difference, only can be calculated when both the measurements are in similar, similar scale. But in cases of many sports, like one score may be in one scale, another score may be in another scale, or some different measurement has been taken, then how do you do that? Obviously then you do standardization. So how do you standardize it? So once you standardize the raw mean difference, you call it standardized mean difference, SMD, simple. That is, which is called Cohen's d. So Cohen's d, or standardized mean difference, is nothing but your raw mean difference divided by your pooled standard deviation. So what is pooled standard deviation? You have two groups, right? One is sample size n1, another is sample size n2, and one standard deviation is s1, another one standard deviation is s2. So it is pooling the standard deviation. So what you need to do is n1 minus 1 into s1 square plus n2 minus 1 into s2 square. Don't go to the formulas, divided by degrees of freedom, and you have a root over it. Now why do we divide it by degrees of freedom, and why do we do n1 minus 1 n2 minus 1? Why not just n1 s1 and n2 s2? So what is this basic thing about degrees of freedom? Can anyone tell quickly, just in a half a minute? Why do we actually go ahead and do n
Be
minus
quick.
1?
Please put it in the chat. Quick, quick, quick. Okay, you have to be very prompt. Okay. Okay. One person has said normalization.
Okay, yeah, normalization. I don't know if I understand what is it that you mean by normalization. To get a standard value, okay,
To get a
normalization in that sense. Okay, yeah, obviously ultimately to have a standard value, but why? Matlab, what is the essence? Why are we doing n minus 1? Okay, just I'll tell. Suppose exactly now for normalization and standardization, I mean to have a standard value, adjust estimates. Anyway, so suppose you have four people, and four people's name are written in cheat, small cheat. One is maybe Rounik, one is maybe Devanjan, one is maybe Sir Satpati sir, and one is maybe the last one Raymond. Okay, last maybe Raymond. So four cheats are there. They are you cannot see what is written, and that is given in a box, in a opaque box. You cannot see what is inside the box. Now you pick up the first cheat. Suppose it's Dhoni comes out. You pick up the second cheat. Suppose Satpati sir comes out. You pick up the third cheat. What was the name? Devanjan comes out. Now, once you have completed the third cheat, you are sure about the last one. It has to be Raymond. So the variability is lost for the last sample. The degree of freedom, the freeness of being variable, being the freeness of varying things, that is lost. Until and unless for 100 sample, up to 99 sample, there are some surprise. You know, he 98 sample can also be a 50-50 variability. 50-50 variability. Before that, the probability increases of getting picked up. But for the last sample, there is no surprise. The freedom is lost. The freedom to be variable is lost. That is why to actually, um, yeah, the degree of freedom essentially refer to the number of independent values in a data set. So to actually kind of, you are saying normalize it to have a standard value, we do this n minus 1, n2 minus 1, or divide it by exactly reducing variability. So that is the main essence of degrees of freedom. Anyway, so this is called Cohen's d. This effect size or standardized mean difference is called Cohen's d. Now one example. So in left side, one study is there, right side, another study is there. In left side, experimental group mean was 10, standard deviation was 4, control group mean was 5. Suppose maybe again hypertension drop, you just think of it. Control group 5, standard deviation 4. So the difference, that is the effect size in the study 1 was 5. But in the second study, the effect size is much bigger. So this is maybe two competing drugs. So left one is drug A, right one is drug B. Again, suppose maybe at gold standard. So which drug do you think I should more keen on starting patients on? The left one or right one? I just told you the Cohen's d formula. And forget about Cohen's d. Just look at the confidence intervals. Yeah, hope this is okay. Yes. Yeah, exactly. The left one. Though the effect size is less in the left one, but if you go ahead and if you see the confidence interval, if you see the standard deviation, it's much larger. Around 14 is the standard deviation. So if you ultimately end up using the Cohen's d formula, the left one is around 1.25 the effect size, whereas the right one is around 0.25 the effect size. So yeah, exactly, ekdam right, perfect. So this is something Cohen's d as a general rule of thumb. As a general rule of thumb, Cohen's d we consider small effect at 0.2, medium effect around 0.5, and large effect is around 0.8. Now, Cohen's d is very problematic for larger sample size. So we use, works best for larger sample size. So for smaller sample size, we use some kind of correction factor, and this is the correction factor. You don't have to get overwhelmed in it with it, and because you are not doing meta-analysis in Excel, though that is excellent to do meta-analysis in Excel, it can be beautifully done. But something this kind of correction factor is used for Cohen's d. There is another one called Hegre's d. So Hegre's d is for very sample size, very small sample size, like 20, less than 20. Then you use Hegre's d. So it uses Cohen's d along with a multiplication factor. Just trivial facts. Anyway, the software is going to do all this part for you. Now this is important, the interrelation, Cohen's d to Hegre's d. Some study may report Cohen's d, some study may report Hegre's d. You can actually come in between the two. And then correlation. Suppose you want to do a correlation meta-analysis, and some study you have Cohen's d, some study you have correlation. So you can change it to correlation with this formula. So just know these things. Can have the slide, and that's all. But again, these are all taken care of by packages or by softwares. Just good to know, that's all. Okay, so for freshers, choosing which model when, the fixed versus random effect model. Look at the left side. In the left side, suppose again we will think of you and your two of your friends working in a in medical or in any other model fraternity, and you want to assess the anemia prevalence in your region. Region means not just in your para, in your area. It's in a bigger area. Maybe you want to find out the prevalence of anemia. So your study one is you, study two is your friend, study three is your another friend. So if it is true, like maybe in your area there is a 1 lakh population. So true effect is when you actually go to 1 lakh people and have the estimate from 1 lakh people. So that is the true effect. Now that is impossible to actually choose 1 lakh people. So ultimately what we end up with is observed effect, which varies from the true effect, right? Study one, observed effect is tilted a little left. Study two, observed effect tilted a little right. And then study three, something like that. So true effect is around 60% maybe, yeah. And observed effect varies between 45% to I think 65% or 75%. So this variance, this deviation from the true effect is due to only due to chance by the methodological error. There are no, like the population is same, which is in reality impossible. Like if you choose a participant from your own village, that won't be same from the participant that is selected by your peers in another village. That may not be there socioeconomically same, may not be there, thousand other factors would come in. But fixed effect model considers that all the covariates that can have some effect on the final estimate is same for all the studies. And with that assumption, they go ahead with a fixed effect model. But in reality, it is impossible. But in reality, it is impossible. So in reality, what we do? In reality, what we choose is a random effect model. So see, in the random effect model, in the right side of the curve, right side graph, the true effect is itself different. For the study 1, the true effect is around maybe 55. The study 2 true effect is around 65, and study 3 the true effect is around maybe 50. This is because there are covariates. You cannot, you cannot adjust these covariates across study. It's impossible. Population is different. Maybe the methodology, the instrument you are using can be different. Many differences has to be there. So in reality, you go for a random effect model in this scenario. So what I feel, what any study which is done particularly on a real life setup, it's always better to opt for a random effect model. Fixed effect model are particularly useful for studies at controlled environment, like lab-based models. You want to know the colony forming units, pooled estimate. So it's a lab-based, lab-grown thing. You can control it. The environment is controlled. Or maybe you want to know the hardness of some dental material. So the hardness tests are controlled. So all the parameters are controlled. In this cases, in this scenario, you jolly well can choose fixed effect, but it's always better to choose in other scenario, real life scenario, the random effect model, because actually random effect model is much robust. If something is fitting in the fixed effect thing, then also you can go ahead and choose random effect. It won't vary your estimate that much, rather it will be much robust. The random effect ultimately uses a correction factor, so that gets nullified if it is almost homogeneous. So anything, that's what our professors used to say, you can do whatever in public health, just logically have the backup ready. If you can logically back that up, then it will be okay. Okay, so the maths beyond meta-analysis. Um, the first of all, you start with calculating the outcome. I told you the coherence d, the effect size. You start with that. Then what you calculate is standard error. So standard error is the how the means vary. If you conduct the same experiment 100 times, how then with 100 means, if you plot them, it will have a mean of means and a standard deviation of mean of means. It's kind of a tongue twister, but this is what it is. So that is standard error. So then next step, you calculate standard error. These are the different standard error formula. For sample mean, it is sigma, that is standard deviation by root n. For sample proportion, if the proportion is known, it is root over p into 1 minus p by n. If it is a difference, then it is, we already have seen in the Cohen's d experiment. Then another formula, other formulas are also there. It is effect estimate by root over effect estimate into the sample size. So many formulas are there appropriate for other many scenarios. I won't bug you that much with this, but just to see what goes behind a software, what it is doing. So next step is computation of the variance. Just standard error square, then you get the variance, and then in step 4, what you do is inverse of your weightage. So that is 1 by standard error square. That is called the inverse of weightage. So
Okay,
now
Rounik,
you have, yeah, yeah.
can we ask them like how many would be interested and feel confident about doing these maths beyond the meta-analysis? Let's have your comments in
Yeah,
the chat.
okay.
Let's see.
Yeah,
Let's see
because
your
I think we should
responses
skip it.
quickly.
Yeah, yeah.
No, no, I'm not asking because of that. I'm saying like in the age of software and digitalization, how many are actually interested to learn about the maths?
Okay, yeah.
Yeah,
Exactly.
that's something which
Exactly.
is often we ignore. We just do everything so mechanically nowadays. We don't even get to the logics and the
Exactly.
maths. I think that's essential. Okay, Ruben is saying I'm interested. Okay, that's good. He's a nurse from Nigeria. So that's good.
Okay.
That's good to see at least one volunteer. Okay, out of 300 plus people who are available now. Okay, let's go ahead. Yeah. Okay, now
So
we
we'll
have
just
lots of
very
interested people.
Uh, I'll be quick
Okay.
because if we actually go to maths behind meta-analysis, then it's a 1 week session. I'm just showing you the fixed effect and the correction factor used in random model. There are multiple effect measures that are used, multiple models are there are used. So I'm just giving you a very layman scenario. Okay, so once we are done with the step 3, that is computing the variance, so then we will do the weight of the individual study. So you have to assign weight to each individual effect size. So there is a model called inverse of variance model. So so it is the simplest way of calculating the weight of individual study. So how does it do that? It's simply, as it is saying the name, it is given inverse of variance. So the weight is 1 by s square. So inverse of variance is the weightage. So once you got that, then you have to assign weightage against the effect size. So effect size is yes, whatever that can be, that 10 minus 5, 5, that 5 is the effect size, the Cohen's d or whatever it is. So suppose your effect size is one of the Cohen's d. So Cohen's d simply multiplied by the weight just you have got through the inverse of variance thing. So now once you have this ready, W into OS, that is weightage into the effect size ready in your hand, then you go to the Q statistics calculation. Now, so what is Q statistics? Okay, so Q statistics is something which is called observed dispersion. So how much dispersion are you seeing actually in your data? So how is it calculated? It is calculated through summation of, so first what you do is you multiply your effect sizes, right? Now just multiply them with, just square your effect sizes, then multiply with the weightage assigned to it, then have a summation. So essentially it is W1 ES1 square, W2 ES2 square, up to nth study. You have a summation of that. Now don't go to the equation, just think about it. What is W into ES square? Once your effect size is there and you are squaring it and you are assigning a particular weight, and weight is what? Weight is the inverse of variance. So W into ES square is nothing but the dispersion present in your data. Okay, so W into ES square, as weight is what? The inverse of variance, that is the variability in your data, and above it is ES square. So it is nothing but the dispersion that your data have. And you have to subtract it with summation over weight into ES whole square divided by weightage. Now see, in this second part of the question, when you divide the numerator and denominator, divide by, in below there is a summation of weightage, and above there is summation of weight multiplied by ES square across whole study. So this is the expected dispersion. Why expected? You are summing, you are dividing, above also weightage is there, below also weightage is there. Weight is what? Inverse of variance, that is variability. If you nullify the variability up and below, what you are left with is the true dispersion that is left in your study data. So essentially Q statistics is your observed dispersion, the whole dispersion you have in your data minus the true dispersion you have in your data. That is observed dispersion or Q statistics. Yeah, so expected dispersion you can also say. Now studies which have no dispersion at all, we tell it the Q would be equals to the degree of freedom, that is K minus 1. So if a study is very homogeneous, if some 30 studies are very homogeneous, then in the pooled analysis, the Q statistics will be is equal to 30 minus 1, 29. So if the Q is somewhere around 29 to 50, maybe 100 also, then it is, you can say that studies are much homogeneous. Not much variability is there in the data set. But as the value gets higher, then heterogeneity will go up. Actually, one thing I want to say about heterogeneity is, you have seen proportional meta-analysis, big bang of proportional meta-analysis coming every now and then. And in proportional meta-analysis, it is actually you will often see that it has a high I square, that is I square statistics, I will tell you. So heterogeneity is always high in proportional meta-analysis. That does not always mean that there are heterogeneity though, because I square is nothing but q minus degree of freedom by q, if I'm right. Yeah. So I square is q minus degree of freedom by q into 100. So that is I square. In the I square, there is variance term, and it is very sensitive towards sample sizes. The I square value is very sensitive towards sample sizes. Now, as the sample size vary, the I square will obviously go up. Now, in case of proportional meta-analysis, as the sample size are very diverse, some study may have been done in with 100 people, some nationalized study may be done with 50,000 population, and you are tagging them all up. So obviously I square is always be high, always will be high. So no matter when whoever reviewer is telling you that your heterogeneity is high and this much high, and what's the point of doing the study, tell them, okay, sir, proportional sir or ma'am, proportional meta-analysis is supposed to have a higher um, I square statistics. This is proved by Cochrane, and you can go and search why I square statistics is higher in proportional meta-analysis, Cochrane review. So they have a whole session for this. They actually went through all the methodological nitty-gritties, and you can actually back that up as a comment. If anyone comes and tell you by heterogeneity, this much heterogeneity in proportional meta-analysis, that's normal. Anyway. So I-square statistics, as I was telling you, it is nothing but q stat minus degree of freedom by divided by q. Just have the essence of it. So essentially, by doing q minus df by q, what is it that you are doing? I told q is what? Q is observed dispersion minus expected dispersion. So the true dispersion in your data. So dispersion minus variability by variability. That is what? That is heterogeneity. The amount of heterogeneity, amount of whole value variability standardized against q. Whenever something like this is there, there is some kind of standardization is done. So this is just that. I square statistics is simply variability. Don't go after the equation. It is just measuring the amount of variation in observed effects that is due to true effect instead of sampling error. Sampling error इसलिए in Q statistics, this part, the second part, is the true expected dispersion due to sampling error. So here I square statistics is not looking for sampling error. So it is mainly looking for variation in observed effect that is due to true effects, not due to sampling error. So having I square statistics very high does not directly tell ki it is not a very solid measure of heterogeneity. It indicates that there is presence of heterogeneity, and that's all. And there are other measures to deal with it, other measures to much better way represent it. But for now, Q stat and I square, both of them are sufficient. So once you are done with Q and I, now the pooled effect estimate will come. This is nothing but in the denominator. Denominator means so upper in the up there is summation over weightage multiplied by effect estimate and divided by the sum of the weight. Simple. That is the pooled effect estimate. That is your pooled meta-analysis result. Standard error, one by variance, sorry, one by weightage, because weightage was inverse of variance. And so standard error, if you back calculate it, it will come root over 1 by summation of weightage. Confidence interval formula, that is the point estimate plus minus the score into AC, 1.96 into AC. So you can actually calculate the whole thing, but this is largely a fixed effect model. This mathematics is a fixed effect model. For random effect model, however, we have this adjustment factor. Now don't get overwhelmed. See, over the adjustment factor um, in the numerator, there is q minus k minus 1. So what I told, if a study have a q statistics of k minus 1, that means there is no heterogeneity. So literally q minus k minus 1 is what? That is the extra variability. Q is the exact dispersion present. So if you subtract q minus k minus 1, so it is the variability in the estimate. So just that, don't get overwhelmed with the other formula. This is something which is used. Leave it. I'll just leave all this. So what is the time? How much time we can go, Professor
See,
Satpathy sir?
we have 2 hours, but you can carry on, not an issue.
Okay,
They are here to
okay, okay,
learn.
okay,
They have to be patient. Yeah, there is
okay,
no way to be impatient learner. There is nothing like an impatient learner. So be a patient learner. Okay, patients are the best learners. Doctors are not.
okay. So now I'll come to heterogeneity and subgroup analysis. Again, I'll just give you examples of it. So it's much better to get acquainted with it. So I'll give you one Cochrane review, which is another stalwart review of its time. The oral zinc supplementation for treating diarrhea in children. So here the intervention was obviously oral zinc supplementation at the doses of 5 milligram per day or more for any duration. Then the control would be either placebo or concurrent supplementation, or so whatever. The control excludes the ORS plus zinc and leave it. So control is something. And then the population is children between 1 month and 5 years of age with acute or persistent diarrhea, including dysentery. Matlab people coming with diarrhea, something like that. And the age group is 1 month to 5 years. And the outcome. So the outcome we are mainly focusing on is the hospitalization duration reduction. So how much time the hospitalization stay can be reduced by oral zinc supplementation. So they went ahead and do a meta-analysis. 33 articles were identified, and among the 33 articles, they after an analysis they saw that around 13.42 hours, by 13.42 hours, this I mean the diarrheal hospitalization episode was getting reduced with zinc supplementation. It's a very nice result. So without a subgroup analysis, if we just present this result and happily start implementing 5 milligram per day, 20 milligram per day, and they saw that around 20 milligram was the average dosage given. So if we start giving 20 milligram per day to all the neonates, all the 1 month to 5 year people, then one problem would be coming. What is that? They did the subgroup meta-analysis and they found out that in ages less than 6 months, it is actually increasing the hospitalization. Whereas in other age group, it was reducing the hospitalization by almost 10 hours in ages more than 6 months, it is reducing by 22 hours. But in case of age less than 6 months, it is actually increasing the hospitalization by around 5 hours. So, which is kind of a concern. You can't give oral zinc to less than 6 month people, neonates. Uh, so from that, the WHO recommendation changed. So right now they recommend 10 milligram rather than 20 milligram, and just because of older than 6 months is okay, but it is literally there is no benefit to possible harm for younger children. So less than 6 months right now it is a notion to give 5 milligram to 10 milligram, but not 20. Before it was 20. So this meta-analysis started the advocacy for change in policy of WHO. So this is what you can, this is the stalwart paper that came out in favor of subgroup analysis. So heterogeneity in meta-analysis, we all were talking about so much till now. There can be clinical heterogeneity. So what is clinical heterogeneity? Heterogeneity in participant, in intervention, and or among the outcome. That is the clinical heterogeneity. So what we can see, what you can measure. Then there would be methodological heterogeneity, difference in study design, or risk of bias due to that. Or there can be statistical heterogeneity. So variation in intervention effect, some statistical technical error, or result variation, something like that. So how to just understand is there are three studies, okay? So A, B, and C, and each study there are three trials maybe, and one diamond, that is the pooled estimate. So in A, you can see that mean estimate are almost aligned. Maybe if we say this is a odds ratio or hazard ratio pooled, then we can say it would be around aligned very near to line of no effect, and it's all aligned like in one place. So that is good, right? But the problem is the confidence interval. The confidence interval are so big. So problem is within the study. So this is called within study variability. The variability or the heterogeneity is not between studies, it is within the study itself. The confidence interval is within each study is much large. So this is called within study variability, the first one, the A. The B, it's very clear itself, they are all over the place. So this is called between study variability. So not within study, here it is between study variability. And C is the perfect scenario. So both within study and between study variability are small. So to measure heterogeneity, we can say first is eyeballing. Just look at the plot and you can actually gauge what is what. See look for overlap. The confidence interval, if you look for overlap, then it is good. If they are not overlapping, like the B, the right part of the graph, they are all over the place. Then obviously there is heterogeneity. Okay, so subgroup analysis. I'll tell you how to write and how to interpret subgroup analysis result. Uh, So this is one scenario. So one by one, I will supply four scenarios. And so here what is done is there is intervention A and intervention B, and the odds ratio is given against some particular disease maybe. So we are essentially seeing which intervention works better for whom. So the subgroup is done based on gender, male and female. Now, how to see the subgroup result? Come to the end. There is written test for subgroup difference at the end of the slide. I mean, below the forest plot, the last line. So this one, test for subgroup difference. If you look at the p-value, it is significant. So that is the first preliminary check. P-value of subgroup difference is 0.04, significant. Okay, fine. Now just don't go ahead and declare it is significant difference among the subgroup. Next, what you need to see is if at all the I-square is dropped between the group or not. Like when you have started this, you have a combined forest plot. The I-square would have been maybe 80%. So after the subgroup, within each group, the I-square value must drop, because why you are doing the subgroup analysis? To account for the heterogeneity. Now, if you have accounted for the heterogeneity through this subgroup analysis, then within each subgroup, the I-square value must drop. Now you see in the female heterogeneity part, I-square is 0. In male also, I-square is 0. So this is the second check that you need to look. Now you can confidently say this is a perfectly done subgroup analysis. And the write-up would be exactly like this in the right part. So a statistically significant subgroup effect, that is gender statistically significantly modifies the effect of intervention A in comparison to intervention B or whatever. So these are trivial write-ups. The treatment effect favors intervention A over intervention B. There is no heterogeneity between results from the trials, whatever. So this is the first scenario. Now come to the second scenario. Here again, the p-value is 0.04. First check done. Now go to the second check. See here the I-square has not dropped. If the I-square has not dropped, that means what? It is residual heterogeneity. Heterogeneity still persists within the each subgroup. So you cannot tell confidently that this is a very well done, not well done. You cannot say but this particular gender or variable is affecting this particular analysis. So again, you can write like this: a statistically significant subgroup effect, that is gender statistically significantly modifies the intervention E in comparison to intervention B. See in the male, intervention A is preferred, but in females, intervention B is preferred. But these are minute details. But the check is that first you look for the subgroup difference p value. Second, you look for if the I-square value has dropped or not. If it is dropped, then your subgroup analysis is okay. If it hasn't dropped, then you need to say that this is not a very potent moderator variable. This is another scenario where itself the p-value is not significant, but the I-square has dropped. So you can see that in female the number of studies are very less. So you can say if we would have found out enough studies, then we would have found out a proper p-value. But although this is a good moderator, but the problem is studies are not that uniformly distributed. So this is another scenario. And then I will just tell you quickly about meta regression. So once you done your subgroup analysis, then you can go ahead with meta regression. Meta regression is something there is called R square. R square value, simply just remember, R square depicts how much heterogeneity could be explained by the moderator variable. So how does it interpret it? I'll show you the result. This is one of our that CKD1 forest plot. So we wanted to see here the p value of subgroup difference is significant 0.07, but as it is being a proportional meta-analysis, exactly the heterogeneity I square did not drop. And then when we go ahead with the R square value, it showed that R square is only 11%. That means 11% of the heterogeneity only was, explained by this, by that particular variable, which is publication year. So this is how R square is useful. This is a stata output. So you simply write meta regress, that is the command for stata. Then you write publication year, comma, and the meta-analysis, random RDML or whatever you give it. You find something like this. So whatever is your importance is R square. So see, just 11% is heterogeneity explained. So which is very low. Now this is also subjective. Many people say 30% is, if it is explained, then it's very good. Many people say at least 60-70%. So it is entirely dependent on your objective. But otherwise here 11% is not a good score. Publication bias. Okay, it's just, so what is publication bias? It occurs when studies with statistically significant effect sizes are highly selected, like that occurred in case of Hans Eisner. So he only cherry picked data which are highly significant. He did not at all take the trouble of finding studies which are much lower effect size or not significant or not published. So in such cases, now how do you look at a publication bias? How do you identify it? You draw a funnel plot. Visually, first is visual inspection. So funnel plot x-axis would be your effect estimate. That can be SMD, OR, RR, whatever it is, whatever effect estimate you are working with. And the y-axis would be either standard error, some kind of precision measurement. Now, remember, for proportional meta-analysis, don't just give standard error or something. It's always better to supply inverse of the sample size in case of um, proportional meta-analysis. There is a paper I would send you. They have nicely crafted which precision estimate should be used in case of which studies. So y-axis is variable, right? Many people uses arcsine transform proportion in x-axis. Many people use in y-axis inverse variance or log of the sample size. So it's very variable. So there are nice charts when to use which one with explanation. I will send you the paper. You can have a look. So this is obviously visually asymmetry is you can see there is something called trim and fill analysis. Have a look at that. So what that essentially do is see that blue bubbles and there are some non-filled bubbles. So those are trim and fill analysis. So what is that trim and fill analysis for non-filled bubbles? They have actually put in that bubbles there. So it is something like mirroring the left side to the right side. So that's just it. And trim and fill, what it essentially does, it thinks if at all there would have been this particular 4 and 5 studies, then how would have been the some estimate is. So I have 5 studies which are maybe asymmetrically located in my funnel plot. I impute 6 studies and make it symmetrical, and I impute effect size automatically, and then recalculate my sample size. And then you need to see if your previous effect size is of at least of similar to that of new imputed effect size. So that is something trim and fill analysis. Have a look at it. Go and have a look at it. So these are various possible reasons for asymmetry in a funnel plot. These are textbook copied thing. So Eggers is a stalwart again. So Eggers p-value is used for looking at publication bias, and there are another Biggs Majumdar's test and all these things for looking at possible publication bias. So publication bias, first look for the asymmetry, second look for these tests, either Eggers test or Biggs Majumdar's test. Okay, so I'll end my session here. I have a art studio hands-on. So if you guys are okay, I can go ahead with that, or we can go with the Q&A. So these are the two books I highly rely on. Just try to download or buy. Matthias Eger. So he is one of the like famous people. If you just search Matthias Eger, you will be astonished to see his citations. He works in University of Bern in Switzerland. He's and Professor Maheshwar sir. If you can bring Matthias Eger in one of your sessions as a panelist, that would be like the day for people.
Okay, let's do that.
Yeah,
Okay.
and these are some preferences. Thank you.
Rounik, I would really appreciate. I know that we are short on time. Yeah, I
Uh,
know you use your time for publicizing your organization as well. But I just want you to give at least 5 to 10 minutes review on
hmm,
how you're doing it. Practical demo, so that because they have
okay.
been asking for it in chat for quite some time.
Hmm,
I think they
okay.
deserve it. Yeah.
Yeah, sure, sure.
So you are going to learn something very practically, but in a very short amount of time. So please focus, okay? Don't be so worried about the certificate. I have to go home. I have to put attendance. This doesn't look good. Please focus on learning.
Okay, so I'll tell you a quick go through of how I do a meta-analysis or systematic review from the very start to at the up to the end. So what things I do use. So whenever I have an idea, have an idea. So I always keep a subject expert with my team. I'll first show you. Okay, so this is how the search template looks like. That I was telling about NUS, National University of Singapore. They have prepared the search template. This one, NUS, this is available in NUS libraries. It is freely available to download. So in the first box, you write your focused research question. And then what I do is here I create another box to kind of define the concepts, or you can do directly here. Like from the first box, from the focused research question, here comes the concept one and here comes the concept two. Then three things are there. Number one is the key concept. So what is the key concept that concept one is covering? So key concept here is the corneal surface defect. And in concept two, the key concept is stem cell based therapy or transplantation. Now you look for free text term, that is the loose term or natural language term. Where will you find it? Simple Google search. Just scout through Google like anything about the similar terms. So whatever terms you can get, like corneal epithelium, corneal surface defect, corneal PED, PCD, whatever. So whatever terms you are getting, just put it here. Same for the concept two. Then come to Medline or PubMed mesh term. Then you come the mesh heading. So try to search for the mesh heading from the mesh library I was telling you. So this is the mesh library. This is called mesh browser. So this is the mesh browser I was talking about. The link is very intuitive, like meshb.nlm.ni. You can just search mesh library. It will come. Mesh browser or library, it will come. So here, suppose I'm searching, suppose pregnancy I'm searching, and I'm looking for an exact match. Then you wait and just come down. See, it has come up with a mesh heading pregnancy. and it has many entry terms. So one is gestation, not many, just one entry term, gestation. So it is telling me to look all these also. Pregnant people, this is also an entry term. You may not find it under mesh subheading or mesh term, but you will find it under other term. I'll show you. Prenatal care. It is a similar term, not exactly related to pregnancy. I mean, obviously related to pregnancy, but as a word, not related to that. Pseudo pregnancy may not be relevant to your objective, but yeah, just have a look. See what are the words that has been used. Okay, so then just go to, once you have identified all this, then go to PubMed Advanced tab. So this is something like this. And see, I was telling about other term. So just put O. So this is other term. So once you put it here, click show index, it will come, and then you have to put it, just click it and then add. And suppose with pregnant people, I want to see, suppose a particular drug, azithromycin, effect of azithromycin may be something. I'll see. Let's see what comes. Azithromycin must be a major topic. I'll see if it is. Show index. Azithromycin, yeah, it is a major topic. Oftentimes it's a trial and error game also. If you don't want to go to this mesh browser, you can do from here also. Just search if it is a major topic, okay? Otherwise, just go to next one. What is that? Otherwise, mesh subheading. So the basically the mesh major topic is like the chapter heading. So how you start, or no, not chapter heading, maybe it's the book heading, the name of the book. So mesh subheading is the chapters in the book, and mesh terms are the keywords in the chapter. You can think like that. And other terms are the loose terms that are found out throughout the chapter. So it is something like that. It's like a tree. In Embase, they are called M tree. So it's like that. So suppose I'll just put it with and simple, maybe not. What can we put as not? Maybe I don't want studies from LMIC countries. So I'll just put LMIC has got many terms associated with it, but otherwise LMIC I don't think you will find as other term, or you can do, yeah, there are. So I'll just put it as add with not. Now the problem is this: if you hit search, you will find a truckload of articles or nothing, because there was no proper article with pregnant people and azithromycin, not LMIC. Just put it in query. Okay, let's just delete that and let's have a search. No, my submission. Okay, there may be nothing, no studies at all available with this. Okay, I'll search you something very familiar. Mhm, mhm, mhm. So see, this is like a, I have not searched in the mesh browser. So this is like a trial and hit. This is not even the other term. Then I'll maybe search in title abstract. What is happening? Mm, yeah.
Is it getting stuck or something?
No, no, no. I was just searching in the query box and putting here. So that's why. So suppose in title abstract, I have chosen pregnancy as a term, and then from the concept to, I'll put up azithromycin. But now instead of making it fixed in title abstract, I'll search in alt field maybe. At least something to will come up obviously. So I'll just put a search. So it has got some 359 results. So throughout the article, wherever in title and abstract, it will find pregnancy, and throughout the whole article, wherever if it can find azithromycin, it will present you those articles. So it works like that. So just this is how we built our search strategy. But how we report is this one. This is the way we report. So this is the midline search term. So all the messaging you will list out. The entry terms you will list out. Then again for the concept 2, these are all the mesh headings that I have listed out from the mesh browser. Then this is your search string. So this is concept 1, this is concept 2, and when you combine them using AND, this is around 2006-14. So this is how, if you supply such kind of search strategy to a journal, it reflects your integrity, it reflects your team's effort. Like it's a tremendous effort. Nothing can go wrong if you have presented things like this. So just that. Again, I was saying M-tree. So if you are searching in Embase, you need to have a institutional affiliation. So I can show you things quickly in Embase. Should I go on, or in later you would show that, sir? I'll just then proceed with other next steps. Yes, sir. I mean to proceed, yes, sir, or I should show, yes, sir. Okay, I'll just quickly show. So for Embase, you need some kind of institutional affiliation, or if you are reviewing some article for Science Direct, they will give you Embase link for Embase for, I mean, for 3 months, I think they give you access. So if you are very novice also and do not know that much regarding Embase, just review articles. Don't think whether I would be capable of reviewing it or something. Just review whatever you feel like you review. No problem. 1,000 people are there to as a gatekeeper. Your one simple review does not ruin academia. So don't worry so much. If something is coming specifically from Science Direct, do review it. Any kind of Science Direct journal.
Okay, so
So
Rounik,
yeah,
do you have few more things to do?
sorry.
Do you have few more things to do, or like do you have to? We can go
No,
beyond.
no, not much. So I guess I will just show RStudio once, because Embase, this is how Embase looks. And there are some search tips for Embase, like field codes are there. You can use app.ti code for searching in abstract and title. There are /de. So it essentially maps your search strategy to all the literature you are searching for. And there are explode option. So /explode. So that's all. And right now, just I'll show you the R. How does it look? So R is something, this is looks like this. This is fancier version of R. This is R Studio. So it has got 4 consoles. And how do you import data in R? So you need to go there and import here from import data from Excel. I have already imported one data frame like this. So it's a data frame which is made up data frame. And there are libraries for R. There are main 3 libraries which are in use. One is mainly called metaphor, and tidyverse for meta-analysis. So you need to load these libraries, and ultimately there are codes. I think some interference is there. So anyway, these are some of the codes. I think I would stop. It's too much because many of the people are obviously it's much uh, बहुत रात तो हो ही गया है. I'll send you the codes, so it's not a problem. R, one thing is R, in R the thing is the possibilities are endless. Whatever you want you can do in R. You want something to be crafted a little differently, you can do it in R. Stata and all these things are pretty not flexible. Like Revman also not that flexible. Even if someone wants a particular setup framework like Revman, you want to have your forest plot, you can do it in R. So that's what about today. I think I'll stop,
Okay.
and any questions?
Yes.
Should...
Okay. As usual, we'll continue with the questions now, Rounik. Thank you so much for the wonderful presentation. There is a barrage of appreciation comments coming in the comments as well as in the question section. So I think you can have a read if you are interested. But um, uh, but we'll proceed now with question and answer. So may I
Okay.
request, to share the feedback form now? Yes, the feedback form has been shared in the webinar chat. Please do not say that we did not see it. If you have been attentive to the session, then I think you will be able to fill the form from the webinar chat section without any difficulty. Okay, please click on it and go to Google Form and fill the attendance and feedback form. Okay, no excuses, no nothing, and do not send any personal messages to me. Okay, so everyone is going to get a certificate of participation from the Global Consortium of Global Health Actors, Leaders and Thinkers, which is the lead organizer of this training program, in collaboration with Global Health Forum, Global Brain and Mental Health Forum, and the Bangladesh Institute of Innovative Health Research, okay, which is assisting us with admin help. So with that, the attendance form has been set in the webinar chat. So all of you, please go and fill it up, okay? And do not leave it. Those who come seeking for knowledge, they generally stay till the end. That's the quality and attribute of a learner. So we need to be more humble about being learners, and that's the only way you will grow and be successful in life, okay? There is no way that you come and attend a session just for a certificate. That doesn't make any sense. And remember, the Zoom premium gives us the access to your attendance. How long did you stay? If you have not stayed for at least 60% of the entire duration, will not give you the certificate. I'm repeating it. If you have not attended the session for at least 60% of the time, based on the Zoom report, will not give you the certificate. Okay, because we are noticing people attending the session only for 10-15 minutes till the at the end, just to get a certificate, which is not at all a good use of a certificate which is signed by me. At least anybody in the entire planet can give a certificate, but will not get a certificate with my signature. Okay, now let's go to the questions. Rounik, are you ready with the quick fire of
Sure.
questions?
Sure.
Yes, okay. Yes, let's do that. So I'll read as they appear in front of me. Okay, Samima Tahira is asking, weighted average is fine, but I think some lacking will still be there. That is her comment. That's not a question. But if you want to respond to that, you can do it.
Yeah, sure. That's what we discussed, right? Ki weighted average is fine, but there are lacking. So lacking is where it is the precision. It does not take care of the variability, the variance between the studies. So in the example I showed, the study B had more participant, and rightfully so, it was given more weightage. But in a weighted average, the amount of weightage was given to it. Actually, in a meta-analysis, it should have given much more weightage than that, which is decided by the inverse of weightage. I mean, inverse of variance method if you use. So that is what. Yeah, perfect. That is the thing.
Okay, no problem. Yeah, people are sending me personal messages. That's how shameless they are. Sending me messages. Egypt said I couldn't get any attendance. Literally, this is the low people are resorting to. I have to say that on live call so that they feel a bit of shame. Okay, because sending me personal message to an organizer, that to a professor, is what people think I am here to respond to those things. Let's go to the next question. Raymond is asking, what's the ideal time for systematic review and meta-analysis? It's a good question, I think.
Ideal time, the duration he is asking, right? How much time should it
Yes,
take?
yes.
Okay, so there are right now things are getting emerged, which is called rapid reviews. So there are people who dedicate their 100%. So if you divide your work tenure in a day, and give at least 60 to 70% of your work tenure behind a systematic review, then even there are studies which are saying ki rapid review they have done in 2 weeks. That is there. But what I feel or what I have seen, a well done systematic review at least should take 6 months, not lesser than that. Anything lesser than 2 months, 3 months, it's I don't know how logistically possible is that. But people doesn't have that much time to invest in particular. They have their life, they have many things other to many other things to do. So a well done systematic review,
But
I guess,
they,
is 3 to 6 months
but
minimum.
Rounik, but Rounik,
हाँ सर. हाँ सर.
many academic organizations, even
हाँ.
academic top institutions are now
Hmm.
all endorsing these AI-based tools, which you can
Yeah.
use and complete the
Hmm.
thing in just 15 days, literally, all the things,
I know, maybe sir, I know it's ekdam perfect, sir. But regarding this, maybe I'm a oldie, so I don't like this
Me the
very
same.
quick
I'm quite
things.
old school. Yes, yes.
Uh,
So I find it really means I'm very skeptical. Honestly speaking, I have mixed
yeah.
feelings
Okay.
towards everything. Yes,
Hmm.
I would rather do it myself than let a machine tell me how it is done and how it should be.
Yeah.
Yep.
Exactly.
Okay, I'll go to the next question. Foka Clarence is saying, I haven't really understood the weighted and the simple averaging, and what are the
Hmm.
chances of using any in a research? Thank you.
Well, not much because it used to be in our like when we used to be small, right? In a class, they used to ask us what is the mean age in your class. So you just used to quickly add all the ages and then mean weight. So add all the weights and then just divide it by the participants number. But in real life, in research, it does not have that much implication, I guess. For a very quick, if there are not many outliers, then yes, it it says something. But if there are too many outliers, too many big or too many small numbers, then it unduly affects, right? And the same goes for weighted average, though it uh, accounts for the sample size variation, but it does not account for the precision. So that
Yeah,
has to be come under meta-analysis.
definitely. Okay, Jusu Musa is asking another question. How do we ensure consistency between reviewers during screening?
Okay, that is a tough job. I don't know. Even I am worried how to do that. So yeah, these systematic review managers are there. Train them well. If they are serious enough, they would pick a good team, I guess. I don't know. I don't know how to answer this. Make the blinds off, um, and they have to be serious. I don't know how else. Train them well. That's all. If
Over,
they don't go.
yeah, over the years, since we are the kings and queens of making psychological tests and scales. In fact, we have taught the entire world how to create tests and scales. Psychologists have taught people. This is our standard profession. We have perfected the ways of coming out with consistency, and inter-rater reliability, inter-rater
Mm.
consistency, etc. There are different, very advanced statistical methodologies for doing that again. So maybe those
Okay.
who are interested to learn about that, they should read more
Yeah.
about psychology and how it's done.
Okay.
Yes.
Yeah.
Okay, let's
Ekdam.
go to the next question. Uthman Adebayo is saying all these frameworks are majorly for qualitative studies, according to what you have said. Dr.
Mm.
Ronik, what framework is best suited for quantitative studies like meta-analysis?
Okay.
Is this
Again, I told
correct?
ki. Okay. So again, I told there is no hard and fast rule. Like if your research question fits with, mostly it will fit with Picot or Pico or Pico, whatever it is, or Coco Pop. These two are exclusively for quantitative study. But even Spider, the evaluation matrix, right? How do you quantify that? Uh, it is, I told you, it is combining two concepts. So one evaluation matrix, if it is anxiety or perception or something, and if you are looking to quantify the anxiety through some score or something, then you can fit it, I guess. So it's nothing like no, if just have your question ready and visualize it, it will come to you automatically, which one to fit. There is no rule, there is no algorithm for it.
Definitely. Definitely. Amar Kanikar, he's a professor, very senior professor from US. Professor Amar Kanikar is asking, are there any guidelines for which database to include?
Well, not guidelines, but these are like, sir, mostly known databases, like I was saying, Scopus is multidisciplinary, and Embase is more biomedical and pharmacovigilance, HTA, all those things. So it is more like if you are doing a study among maybe paramedicals, then you must choose many softwares, like many depositories like APS, ICNIT, Sinahal, and all those things. So it varies from one thing to another. One thing I want to say for search strategy, there is a checklist called press checklist. So if you want to have your search strategy like next level, so you can supply this press checklist along with it. But mostly for medical literature, PubMed and Scopus, Embase is fine. And social science, obviously Scopus, psychology, APS, ICNIT, it's like that.
And Senal, the one that you sold.
Yeah, sir.
Okay. Let's go to Clinton Frimpong. He's asking, please did you mention Google Scholar is not suitable for search articles if you're doing your search for the review?
Well, Google Scholar, it's not nothing. It's a very wrong statement, I should say. But don't write ki we have used Google Scholar for search. Like in your database, Google Scholar is not a database. It's essentially a search engine. It is best suited for citation chasing at best. But I don't know. Like these are like person to person opinion differs. I'm a very novice researcher, so my small opinion is that I
I
generally
think
don't tend to.
anyone who doesn't have advanced access databases like standard databases should be able to find some amount of good literature on
Yeah,
Google Scholar. So that
yeah,
way,
that's
very
what.
good.
Then there comes the A of collaborator. Find a library and you will find someone with the access. You will find, definitely you will find. Don't be like in authorship sharing तो करूंगा नहीं तब तो नहीं होगा. Share the authorship, find a library
Okay,
and good one.
question. Ronik, by the time is increasing, the questions are increasing for you.
Yeah,
Okay,
yeah,
so let me
please
read
tell.
out quickly, and you have to be very
Yeah,
quick in responding to them.
yeah, yeah, yeah.
Anisha is
Okay.
saying, sir, could you please explain how to make search strategy customized to my research question? Your research
Yeah,
question is not known to us, and you cannot disclose that here. So, Anisha.
I'll send sir the search template. It's very intuitive. The things are very nicely written. Once he shares with you all, I think you would be able to do that. And then see some YouTube videos. It's all available. Anyways, has got around 30 videos. So I learned from that 2 years back. So please go visit that.
Those who have a desire to learn, they will learn it from any source. The universe
Yeah,
is
exactly,
the
sir.
mother of
Mm,
learning, as they say.
yeah,
So there is nothing that will block them. Okay, Raymond is asking, how do we handle overlapping populations across studies?
yeah, okay. So overlapping means how do you define overlapping? I'm not very clear. Is it heterogeneous population you are talking about? Different? So if it is too different, then a systematic review is sufficient, not a meta-analysis maybe. But if it is almost similar or something, then you have to use the random effect model. Then heterogeneity will obviously come. Then you have to search for the reason for heterogeneity, which is through subgroup analysis. And after that, if you want to go another step ahead, you can do first univariate meta regression. Then you can do multivariate meta regression if you find more than two variables, which is affecting the point estimate. So all these things you can do. Um, this you can.
Okay, let's go to Ananya Roy. She is asking, is mesh a part of PubMed or both are different?
Okay, so no, not like the mesh means medical subject heading. It's a term. So so it is mesh heading. Like I was telling, chronic kidney disease. Whenever you submit an article, think of this like that. Someone is sitting and some 3 4 foods are coming by, and you look for biryani and you just snatch it. So PubMed is something like that. Article comes by, authors have given some 4 5 keywords, and among that one particular keyword which is of the main thing, a major thing, PubMed has indexed that. That is called medical subject heading. So that is how PubMed categorizes each article. So CKD, chronic kidney disease, it will take any article with CKD and have that in a box. So it's like that. So medical subject heading is the term indexed in PubMed. So that's, I take it.
Sampriti Roy is asking, what is the Prisma flow diagram?
Yeah, okay. Well, I completely missed it. So Prisma is a standard checklist for a systematic review meta-analysis. So preferred reporting, something was. I always tend to forget. Even in my Viva also, I fumbled what is the full name of Prisma. And anyway, so it is a checklist how to. Uh, so there are many things. Flow diagram is how you are searching for the study, starting from databases you have used, how many articles you found, how many screen, how many got deleted or scrapped out. Then it's a complete workflow from search, inception of search to ultimately the final written articles. So this workflow is presented through a Prisma flowchart. So first you start with PubMed, maybe 300 articles. So like that you come narrow it down to maybe two articles you have retained. So that is Prisma flowchart.
Okay, Prisha is asking, sir, what is the best way to use PubMed effectively for biotech research?
Well, I guess I have shown you. Biotech means biotechnology research, PubMed, same thing. You fix your objective, what you want to search for, and the way we were showing you how to search, coin for the mesh headings, coin for the mesh terms, identify the concepts, and then just search random. That's all. Be a quick hit and run. Many times you will find like today it happened, right? Nothing came up. So that will happen. Just tweak your search strategy little by little, it will come ultimately.
Yeah, okay. Jusu Musa Sierra Leone is asking, is it necessary to register a systematic review protocol?
Well, obviously, because see, the thing is, suppose this you are undergoing having an idea to have a study to do a study, and just 1 year back that study is already the same study that is already done. Then it's a wastage of time, right? At least 5 years has to gone by. Otherwise, it's a wastage of time, duplicity of yeah. So if it is a registry is there, first of all, it kind of becomes standardized because they ask some questions, right? Whenever you fix some questions, you have to answer that. Then you kind of write a protocol because most of the us do not apply for ethical clearance for systematic review, but many of the colleges do. It will have an ethical waiver, but at least it goes up to a panelist. But that's why registration is must important. And right now, Prospero is not checking, na. At least registered. At least you will have a protocol
Yeah.
type thing to start with.
Okay, Arindam Mishra is asking if I want to. It's actually funny the suggestion that you give. Okay, Arindam Mishra is saying if I want to conduct a systematic review on the effective sensitivity and specificity in bracket screening for early detection of esophageal cancer screening, can I do?
Yeah, again, where did it go? So anyway, if I understood the question rightly, you look for your effect size first. You fix your research question. You look what effect size you need to pull. If some screening is reducing some cancer, then how do you measure it? The outcome would be measured either time to event data, hazard data, survival data, or something, some quantification measure. Now, once you identify the outcome, then you look for literature. If enough studies are there which have reported that particular outcome or not. If enough studies are there which have reported that particular outcome and more or less similar setup they have been done, then yes, why not? Meta-analysis you can do, but if you cannot find much data about it, quantifiable details are too heavy, then I guess you have to resort to a systematic review again. So that it's not like if I can do, it's like you have to find out through your effect size what do you take as effect size and search it if enough studies are there or not.
Mhm. Okay, right. Uh, okay. Ponti Vacharapon is asking, when using PubMed, how can we determine the appropriate keywords for research and ensure that all relevant terms are included to conduct a comprehensive literature search?
I guess I already answered this. Again, same concept and then find out all those things. So this one is already answered, right, sir?
Mm. Okay. Yeah, that's what I thought as well. Okay, Raghavendra Kumar Mahato is saying, can you suggest any tools to interpret forest plot and diagram of meta-analysis on different outcomes?
Forest plot is something you make. How to interpret that? To interpret a forest plot, there is no software. There are AI-based tools, right? You can just upload your forest plot there and ask AI to interpret this forest plot for me. That will. Is that the question? Is that I got it right? The question. If that is the question, yeah, then AI tools. Simple. Interpretation, though, matlab, you have to learn and then you have to
I,
report.
I
So,
have marked it. Yeah. They are in learning pages, so they are asking all sorts of wild questions. That's
oh,
fine.
okay, okay.
Okay. So, okay, many requests are coming that they want to get your help in terms of database access, access to paper. We found you, so will you help you? Will you help us? And then etc. etc. All sorts of requests are coming up. My thing is like our participants are going to cause you a little bit of hassle, Rounik.
Okay,
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 so
no
you
issues.
have to come on board and mentor them a
Mhm.
little bit. Okay,
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 sure, sure.
because they're new to SRMA. So this is my
Okay.
personal request as well that you have
Yeah,
to come
sure,
and
sure, sure.
help them.
Sure.
Okay, there is one thing
Hmm.
saying
Yeah,
calculate an
sub
example practical session schedule, say for another day using Stata.
Stata actually I don't use. Yeah. If I have to show you in
No,
Stata, then I have to learn first. RStudio I use. I
yeah,
can have a session for RStudio.
yeah, yeah. The Art Studio is very good. Art Studio is very effective, but the only issue with Art Studio is you have to have a little bit of basic background knowledge of programming, you know,
A
without
little.
which you
Not
can't.
much, a little, sir.
Yeah, yes, yes.
Acha, someone asked,
And
I can see a
another person,
question. Did you use prediction intervals in your analysis? If yes, how are they different from
okay,
confidence intervals? Yeah. So yes, I do use prediction interval in my analysis. So this is something like saying ki in future, whatever study are going to get conducted, whatever meta-analysis is going to get conducted or study for that matter, it will fall within that. It will be predicted. The prediction would be ki that particular outcome would be within that. If you see the prediction interval are generally very wide. Like confidence interval is much narrower, but prediction interval will come somewhere from maybe the range would be 100, somewhere the range maybe 50s, 40s. So it is essentially saying in future, whatever studies are getting conducted or something like that, the predicted interval would be falling in that particular area.
okay, okay.
Confidence
There is
interval,
there
you
is someone
can,
who
yeah, yeah, please go ahead, sir. Please.
okay, okay. Yeah, yeah. There is someone named Aminja Rashid. I am reading her comment. It's one
Hmm.
of the most offensive and very hateful comment. Written by her shamelessly on this platform. So, Hazel, I'm putting you a note. Please note down this person's name. We'll block her and we'll blacklist her. From now onwards, you'll not be able to join our sessions. She's writing. Firstly, the session was very interactive. Secondly, why are you smiling so, Satpati ji? And she put the same comment twice. I think Dr. Ronik is also hungry, so please end the session. If you have so much of eagerness and so much of hurry to go and eat your Eid food, then go to home. Who is blocking you? Who has called you here? Have we sent the invitation to your home? We have not sent the invitation to your home, right? So do not show this shameless face of yours here ever in the future, and do not post such hateful comments in our platform. We do not appreciate it. Okay? And Faisal, are you able to listen to me? Faisal, he has gone. Okay. I'll personally write down so that I will personally remove this person and I'll blacklist her. Will not allow such useless, headless, hateful people on our platform. Okay. Okay. I think Dr. Ronik, you have answered most of the question, but there is one question which you must answer. Jusu Musa is asking, what methods are used to assess publication bias?
Yeah, okay. So, first of all, publication bias. Um, First is your intuition. Have you included all the studies? Have you done your search very well? Second is funnel plot asymmetry. Visually, just look for asymmetry in funnel plot between the two. A, two sides, and then after that do a either Eggers test or Biggs Majumdar test. So either, so you have to report all these three. So visually symmetry was found, but maybe Eggers test was not positive, p-value was this, and there was no publication bias, or there was publication bias, or something like that. So Eggers test, Biggs Majumdar, and this one funnel plot is sufficient.
Yeah, yeah. Many questions are around what textbooks to go for, best book to read, etc. There are very good questions coming up, but I think we have crossed the time quite a lot. But I think anybody who is truly interested, they would stay and they would listen. So what I'm trying to do is basically read out as many questions as possible. What type of framework is feasible for policy analysis of the country or a policy analysis of specific topic of different country? That's what Moon is asking. But this is beyond
Okay.
the scope of
Yeah.
this particular thing.
That's what. To answer you, I have not. I think this is like as Sir said, this is not the right place. But just follow Smith's policy analysis framework and use WU someone. His policy analysis framework, power framework. So just you can search, right? These will come. These things will come. This is not a place for that.
Yeah, certainly, Dr. Rounik. Okay, Dr. Firdaus is okay. These are very old questions. I think they have been answered. So most of the questions you have already answered, Dr. Rounik. But Raghavendra Kumar Mahato is asking. This is the last question I'm asking. Can you suggest any AI tools to find research gaps and limitations, like doing while doing screening, basically?
Okay, so one research AI tool has recently come up called Anada. You can have a look at that. But all of these like basic search are free, but basic search is not sufficient. Research Rabbit is good. Litmap is good. Anara is I find quite good. And EGM, Evidence Gap Map, to try once. It's really
Okay,
good.
good. Okay, right, right. Okay, so I think you have answered a lot of questions, and that shows the amount of patience, the amount of passion, the amount of conviction, the amount of commitment to learning and research that you bring, Ronick. And I'm extremely grateful to you to come on
I'm
board
also
and train our participants. I do not, uh, I do not think many of them are able to realize as yet, but hopefully they'll realize one day the amount of time and resource or everything that we are putting in here to support them, and hopefully they will also make the best use of this knowledge and skills that they have gained in today's session, and they have been gaining in the Global Advanced Certification Program as well. With
so
this,
thank
I
you, sir.
think
And yeah,
we have done
I
a
mean,
great
I just
job.
want to
So
say,
let me just
I
quickly
just,
say,
yeah.
yes, you will give your thanks speech later. Just let
Okay,
me
okay,
say
okay.
a few important things. Yes,
Okay.
because being the program organizer is one of the toughest jobs, and people send such hateful messages. If you are so hungry, go home eat. Who is saying you know? You're
That's
at
what I
home.
wanted to
Your
say.
camera
This is a
is off.
very tough job.
Yeah. Yeah, so my point is that your camera is off, you can eat food, and we are trying our very best to cover such a very vast topic in such a small amount of time. You need to be, if you don't have true appreciation for learning, you should not be here. This platform doesn't belong to you, to be honest. It may hurt you, it may offend you, but that's the truth. That's the most naked, brutal truth. Okay, my point is, like, being the organizer, let me just say a few things. First thing is that thank you for coming on board. It was wonderful to have you on board, Ronnie. All the learners who have actually attended the session at least 60% and above of the time will be granted a certificate. I will personally sit down to monitor and filter this time. I will not let Faisal take a decision. And so those who are listening, please note this, and this will be communicated in writing as well. So it's not like we are going to allow the certificates just like this with signature on it. And you will have your signature, Dr. Rounik Talukdar, on their certificate as well. That's the tradition of our global consortium, that the trainer who comes to train them will have their signature printed on their certificate. Okay, which you might have noticed probably on LinkedIn. Many people are saying
Yeah,
that.
yeah.
So all the participants, those who have attended and those who will be eligible to receive it, share it on LinkedIn so that actually you get more visibility. Okay, because many top people do like them, comment on them, and that actually enhances your visibility on LinkedIn and such professional platforms. And actually that may give you better visibility to actually be noticed as a prospective employee, because you are getting to spend your time on learning and getting trained and upskill. That's very, very essential. People do take care of it and do take note of it seriously. Okay, with this, I think I'm again thankful to you, Dr. Rounik. We are very, very happy to have you, and I think you have done full justice to the entire program. Within such a small amount of time, you have covered such a vast topic with such clarity and depth. And so, therefore, uh, I, on the behalf of Global Consortium of Global Health, the Global Health Forum, and the Global Brain and Mental Health Forum, and the Bangladesh Institute of Innovative Health Research, want to thank you and want to place a note of appreciation which will be offered to you by email, a certificate of appreciation which will be sent to you very soon. Okay, and our admin team would be in touch with you to seek your PPT. So please provide that, because many participants are going to eat my brain. They're going to pick my brains on this in the next few hours, literally. So it's better that I get it as soon as possible so that I'll be able to share with them. And keep smiling is the key, my dear friends. Okay, if you don't smile, and if you have to spend an entire 3 hours 4 hours training session, and if you don't smile, then by the end your face will become like a murjhaya fool. Okay, it's better to look like a fool rather than a murjhaya hua fool. Okay, so I think I hope you got my point. Okay, so it's better to look like a fool rather than a murjhaya hua fool. So look alive and rather than being dead. Okay, that's as simple as that. So thank you. Rounik, if you want to say a few closing words, that will be great, and then we'll close.
Thank you, sir, for having me here. I don't know, it's a tremendous job. Like organizing with 300, 400 people. I don't know how do you manage. And I keep seeing you working till past 4, 3 at midnight. And then again, morning, you are starting meeting and everything. Hats off. This extraordinary work you are doing. So I hope I can do
Actually, my
fractions of
participants
that.
are getting they're getting worried about you more than me. You know, they're asking you to go and have dinner. Okay, no problem. So
Okay.
let them go and have fun. The
Yeah.
participants have already received the attendance form, so please go. It will be closed in just 5 minutes time. We'll close the attendance form in 5 minutes time. I'm repeating. Okay, so please go and fill it up. After that it will not remain open, so do not come to personal chat to me to request for it. We'll not extend it. Okay, with this, Dr. Talukdar, it is my formal
Thank you.
duty to say thank you again, and we'll close with this, and I'll be in touch with you, and the admin team will be in
Yeah,
touch.
sure.
Okay, and I look forward to welcoming you once again, not as a trainer but as a mentor to our trainees. Okay, yes,
Sure,
that
sure,
will
sure,
be
sir.
my absolute pleasure to welcome.
Thank you.
Okay,
Thanks a lot, sir.
thank you.
Bye.
Good night. Bye.
Good night.
Okay, now the participant, those who are left out. Okay, we are quite late. Okay, so we'll not be having the uh, leaders meeting anymore, because you do not seem to have a lot of interest. It doesn't. If you have interest, then you can put it in the comment that you want to carry on. If you do not have interest to carry on for the leaders meeting, then you may say we are not interested. Then on the basis of the highest number of votes, we'll go ahead. Okay, otherwise we'll close. So can I have a raise hand of like who want to stay the leaders meeting?